was at the time. But the first report was in June of 1981 when I was a medical student. And we've moved on 40 years. And to put in perspective how much HIV and science has advanced, at the time it took about 4 years to develop a test and identify the organism, the virus that caused it. And if you contrast to that, to how quickly they identified the causative agent and a test for SARS-CoV-2, it was within a month. So it just shows you the importance of science and how quickly it was done. So why has there been progress? And these are the tools that are really important for you as a region to, it's the same tools as before. It's about communication and education, and these are the four in which you can do that. And many of you are the voices for people who don't have voices in the region because of stigma. And that's where the dedicated healthcare professionals come into account. We, certainly in the early stages of the pandemic, were essential in delivering care. It's about community engagement, and I'll talk about this at the very end. There's no point us as educated healthcare professionals telling our population what's best for them. It really is about community engagement, particularly for those that are marginalised. It's about advances in therapeutics, and the conference here today is sponsored by many of the pharma companies who've really been instrumental in the research and development of where we are today, essentially 1 tablet a day with a normal lifespan once you identify those that are HIV positive. So that is a huge, huge success. It's about research and ongoing research, both locally, regionally, and also internationally, and the importance of collaborations in that research. And finally, it's about advocacy. Certainly when I started back in Ireland, the stigma and discrimination that was associated with having HIV/AIDS was huge. While we've big cities, we've a lot of rural communities, and people felt that they didn't have a voice. So it's important to interact with advocacy groups, but also to be the advocate and the voice of your, for your patients. So what are the benefits of the HIV strategy? Essentially, it should be to end the HIV pandemic, and the benefits of a national strategy or a regional strategy is a common vision. And the goal is to prevent new HIV infections, to ensure people know their HIV status, ensure all HIV-infected people have access to care in a safe environment, and ensure all HIV-infected people are free from discrimination and stigma. And a strategy should be developed by subject matter experts, many of you who are in the room here today, but with key stakeholders, and whether that's you as a general physician who have to look after HIV patients, your input into it, into any strategy is absolutely key, because there can't be a specialist in every clinic within the region. You need to have key performance indicators to measure progress. There's no point in putting money into an area unless you know that it's been cost effective, and to be a useful and accessible roadmap for all sectors of society. So countries are at different stages of epidemic situations and epidemic response. So sometimes you can't compare like with like, as happened with the COVID pandemic, because the way we live and the way we interact is different. Each country should consider developing a national strategic plan that serves the needs of their population. So you can't just extrapolate what happens in North America and bring it here, or Ireland. You need to know what it should be guided by the national data that you have on your HIV population. It should set priorities based on the evidence, the capacity, the resources, and the cost effectiveness of the interventions. And as I said, and I think this is really, really important to stress again, it should engage key stakeholders and the affected communities. So what are the challenges? Do HIV national strategies work? Yes, they do. You can see here data from the States from 2015 to 2019, where initially the intervention showed a flatlining, but more recently there's been a decline with the plan to bring it to about 3,000 new cases based on the strategy that they have. So, but as I said, it works, but not equally. So people, if you look here in the States, those that are most marginalized, people in minority populations are the people that are most affected. So there are inequalities by geography, by socioeconomic class, and marginalized and at-risk communities, even in the most developed areas in the world. So yes, strategies work, but not equally, and that's why it's really important to consider who the marginalized communities in your areas are. But there are challenges for all national disease-specific strategies. I, as an infectious disease physician, think strategies around infectious disease are more important. But if you talk to rheumatologists or endocrinologists, public health doctors, they will have different strategies, so we compete against one another. There are competing healthcare needs by disease and demographic. We have aging population. We have the health burden, an increased health burden of chronic conditions, whether it's diabetes, obesity. They all have a huge impact in how we do it. We have a limited pot of money, so we do need to prioritize, and we need to be conscious of the money that's allocated, but again, advocating for our patients. There are global workforce shortages that will impact on how we deliver any strategy. There are emerging health and socio-political issues that are unpredictable and complex. We've seen it certainly in Europe and globally with the pandemic, but also the war in Ukraine, which is causing recession in and increased diversion of resources to a large refugee population. There are health inequities, and we see those all the time in infectious diseases. Governments want to prioritize things either for political reasons or because of the needs of the population. But we do need robust surveillance systems to allow us to, again, advocate and prioritize for what's needed. So looking at the continuum of HIV prevention and care, this is what UNAIDS has set as targets. So diagnosing 90% of your populations living with HIV, of those 90% on antiretroviral therapy, and of those 90% should be virally suppressed. So about 70% of all HIV people living with HIV should be virally suppressed. But it's not just about reaching those targets, it's about monitoring the quality of care. There's no point in diagnosing people if you can't link them into care and if you retain them on antiretroviral therapy, because at the end, what's really important when it comes to prevention and better quality of care and normal lifespan is having people virally suppressed. So here is some data. That's the aspiration. You need to see if the aspiration measurements are following, and this is in the US, where 87% of those that are diagnosed, only 57% are virally suppressed, so certainly could do a lot better. This is in Ireland, people living with HIV, 100%. We've got about 60, so 2/3 of those are virally suppressed. So it's about identifying, linking them to care, and then really importantly, getting them retained in care. We really do need a holistic approach to linked health issues. And for those of us who practice a lot of HIV medicine, we know that many of our patients, the least of their problems are HIV. They often live in poverty, they've co-infected with viral hepatitis B and C, they've mental health issues, they've addiction issues, HIV and STD. So these are often treated in silos, but we really should be linking, and I know that there are talks later on about STDs and HIV. That's a really good place to start. But linking everything together is really important, and certainly in Ireland, I know, I can tell you, we do work in silos, but we should be working more closely with other services. We also have the future challenges, emerging and expanding health needs of an aging population generally, but in particular with HIV. And you'll see here by 2050, a fifth of our population will be over the age of 60. Comorbidities, and again, this will be spoken about a bit later, hypertension, obesity, high cholesterol, we see all of these in our population. Neurocognitive dysfunction, again, they'll be talking about this later. Bone health, and the new unknowns, whether that's long-term impacts of therapeutics, but also hopefully things that will have come from the pandemic, like more knowledge, more vaccines on treatment and prevention. So what are the opportunities? On the positive note is the toolbox we have. So looking again and reiterating what I said already, it's about prevention on one side, and it's about treatment on the other. And with the prevention, it's about linking HIV with other STD screening, and having that has a huge impact on HIV prevention. And once you're diagnosed, effective treatment, linkage to care, primary care, and for those of you who do general medicine and other specialties, linking in with the specialty centres. A lot of HIV care is fairly straightforward, but we all have very complicated patients, and they're the patients that you need to get into the specialty centres with the colleagues you've here, and really prevent and treat that syndemic infections, all of the other things that are linked. So looking at prevention, again, I can't state enough the importance of national data to target and prioritise prevention strategies. There are national leads and at-risk populations within each country and within each region. Stakeholder engagement, reiterating that again. A syndemic approach, and that's mental health, addiction, STD screening, viral hepatitis. Acceptable therapeutic approaches. Education and behaviour, and novel technologies. And this is the toolbox we have for prevention. Basic things like HIV testing, more costly and sometimes not hugely acceptable, things like PrEP, post-exposure prophylaxis, and treatment as prevention, the ability to get people to virally suppressed, and many of the other areas here that are really important, but this is our current toolbox for prevention. What about the opportunities for treatment? The agreed approach to therapeutic options, and this is where you can get together as communities and work on formularies agreed that ensure good safety and quality of the therapeutics we give, that they're acceptable to those who need to take them. It's fine to give medications, but people need to understand the importance of them and make sure that they suit their lifestyle. They need to be cost effective. Again, we have a limited resource. And you need to benchmark against what the best outcomes are. The targets should be linkage to care. You should be monitoring that. Again, people who come into care, they need to be kept in care with retention. And then you need to virally suppress. So these are fairly straightforward targets to do, but sometimes difficult to implement. And again, this is our treatment toolbox, treatment of co-infections and comorbidities, and then all the treatments we have. We have the single tablet regimes that many of our colleagues that treat other chronic diseases wish they had. and the newer, longer-acting regimes and where they fit into your toolbox. So again, there'll be a talk on the impact of the pandemic on HIV prevention and care, the challenges, really highlighted, certainly in Ireland, our weaknesses in existing public health structures and our ability to truly do good data surveillance and have data inform how we deliver care. And there was diversion of resources to a single disease entity across all things in medicine at the time. But there were opportunities, and there are opportunities. We certainly have a very educated population on the prevention of infectious diseases. I never thought that I would hear people talking about variants over coffee, vaccines, AstraZeneca, Pfizer, mRNA. These are common parlance in our populations. The use of rapid tests, and that should include point-of-care testing in the community for HIV and other STDs. These are acceptable. People see the visual in front of them and will take appropriate action. We've used and can use mobile and telehealth, particularly for those that live more remotely, to monitor them, particularly if they're compliant. We had data-driven decisions. We'd strengthening of our existing public health infrastructure and increased, exposure and prominence of our infectious disease colleagues. We have research and development, and we have global connectivity that we did even when we were confined. In Ireland, it was even to a 2-kilometre radius.
Prof. Mary, 2 minutes, please.
Yeah, this is my last slide. So I'm going to quote Dr. Anthony Fauci, 4 decades of HIV/AIDS, much accomplished, much to do. I had the privilege of having a fireside chat in our home remotely in the College of Physicians, and he was a huge advocate and really did so much to advocate for HIV and AIDS and involve the communities they impact. And that can be very difficult because of stigma and discrimination, but you will find people who will be engaged and be a partner in delivery of effective national strategies. Thank you.
Very much, Prof. You really brilliantly paved the road for the coming presentations over the 2 days. Thank you very much. For the shortage of time, we will not have panel discussion for this session. So if there are 1 or 2 burning questions for the Prof, we can take them. Okay, so if no questions or comments, thank you very much again, Prof. Mary.
Thank you.
Thank you. So it's my honor to introduce Dr. Jumana Hermes from Lebanon. If I can introduce her as HIV manager, Dr. Jumana. So she will be talking to us about the update of the statistics of HIV in the Middle East. So the floor is yours.
Sabah al-Khair, good morning. Can someone help me with the presentation? Put it up. Final presentation. So thank you for inviting me to be here. So good to see all the new colleagues in the field and people from the international community working in HIV. I think it's a high time now that we rethink our HIV response, especially with the monkeypox coming up, affecting the same groups, affecting people living with HIV, and the connection between the risk factors and the risk groups. So rethinking the HIV response also guides us in responding to other emerging epidemics and health situations. So I'm from the World Health Organization, Regional Office for the Eastern Mediterranean. I'm based in Cairo. I'm the Regional Advisor HIV, Hepatitis, and STIs. So I'm glad to be here. I will be presenting to you the epidemiology of HIV in the region, and you might hear other statistics from other places because the Eastern Mediterranean region comprises countries all the way from Morocco to Afghanistan, while the MENA, which is commonly used by other people who report on it, and according to the UNAIDS division of regions, MENA does not include Afghanistan, Pakistan, and Iran. So my data will be different from MENA, but this is the Eastern Mediterranean. So where's the thing? What I will present to you today is the results of a multi-country program review that we conducted in my team in HIV WHO regional office. We will talk about the epidemic state, then the regional response to the states, and the determinants of low performance in the region. And after that, I will present to you some glimpse of the regional action plan for the implementation of the global health sector strategy to respond to HIV. So in background, just to show you in these pictures, you see that in our region, in the graph on the right, in our region, there is persistent rise in incidence of cases and in death, while this is not in the rest of the world, where we see decline in incidence and decline in death. And if you look at the graph on the left, you see that we are running to increase coverage of treatment, while the epidemic is running ahead of us. More cases are coming, so our coverage remains low because the epidemic is running ahead of us. And this explains also the continued increase in infections, because as we heard, treatment is prevention, and continued rise in death. So this is the map of the Eastern Mediterranean region. The countries that are colored in blue, different shades of blue, are the Eastern Mediterranean region. And the darker the color, the higher the burden of disease in those countries as absolute numbers. So sometimes the population is too big, so it presents large numbers of people living with HIV. And if we calculate the burden of disease in the region, we find that almost 90% of infections are concentrated in 7 countries. Half of them in Pakistan, and the other countries are Iran, Sudan, Egypt, Morocco, Afghanistan, and Yemen. And the rest of the region is only 10% of the burden. And we have noted that over 90% of the new infections of HIV happening in the region are actually affecting key populations, namely people who inject drugs and MSM, and transgender groups in the highest prevalence, followed by prisoners and sex workers. So the most reported modes of transmission, this is reported cases, what countries are diagnosed. You see that the majority of cases that are diagnosed are heterosexual. Although more infections are happening in the key populations, we see that more infections are reported in heterosexual community, and this is due to the testing strategies that are adopted in the countries. We have less reach to high-risk groups and more reach to general population. The second biggest group is people who inject drugs, and that's almost 1/3 of the cases in the region, followed by MSM. Of course, we have a big group which is unknown, and this is due to the stigma and due to the taboos where people don't report their mode of transmission. Sorry. I will not go through this table very thoroughly, country by country, but as you see that prevalence in all countries is between 0.1 and 0.2%. However, if we look at the availability of data to estimate the number of people living with HIV, several countries have no data. They didn't go through the estimation exercises, and no forecast or no estimation of new infections or the data on death that is incomplete in several countries. And accordingly, we cannot calculate for those countries that have no complete sets of data, we cannot calculate the coverage or the cascade of care because it's all, one is dependent on the other. And also another note to make here that you see that upper middle income countries, I think this is a pointer. We see that upper middle income countries have better coverage of services, better coverage of services, better cascades. I can't find the pointer. How do I do the pointer? I found it, I think. Okay, so basically you find the first set of countries, which are the upper income countries in the region. We don't know about the first 90, which is the testing, because we don't know the denominator, but we know of the testing with the treatment of those who are diagnosed. We see high coverage of treatment and relatively high viral load suppression. While you look at the low-income countries, you look at the lowest set of countries, the bottommost, you see that the coverage is very, very low in terms of the last three columns, how many people are diagnosed and how many people are on treatment and how many or percentage virally suppressed. So this is what we call low performance of the region, and we will go through more in depth to look at the reasons for this low performance. So in general, we have estimated 420,000 people living with HIV. That's our 100%. Currently, 41% are diagnosed, 27% are on treatment, and 24% are virally suppressed. While the rest of the world, we heard in the previous presentation, the world is around 70% diagnosed and close to closing the other 290s. So what are the determinants for this? This is also by countries reported to WHO. Annually, countries report to us what they have tested and what they found positive. And if you look at, I really would like to see the pointer. Okay, so if you look at the first bar chart, this is the distribution of tests done, and by each color represents a population group, and the first 5 bars are key populations, basically. People who inject drugs, men who have sex with men, transgender, female sex workers, and prisoners. So to look at this, these 5 bars represent basically around 12% of all the tests conducted in the region. While we see the rest is the blue, for example, the light blue is premarital couples. Okay, great. The first one? Yes, thank you. Thank you. So I was talking about these. These are the key population tests, and I'm talking about the rest here. We have this green. This is healthcare settings, TB, STI clinics, antenatal care, etc. This is the group of premarital tests, and following that, the orange is migrants, and the rest is others being offered tests. We have a group called clients of VCT. This is a old terminology used by countries where they refer to any site where they refer suspected cases for confirmed testing. So this is what they call VCT. So this is the distribution of tests. As again, I say that only 12% of the tests were for key populations. And you look, where did we find the positive tests? You find that those 10% were actually where we diagnosed 30% of the HIV cases. So all the rest, you can consider it inefficient testing, except the healthcare settings, of course, where we have TB and STI clinics and antenatal care. So 30% of the diagnoses were made in key populations, while we were spending our testing resources on low prevalence population groups and inefficient. Look at the premarital testing, which has taken almost also an equivalent amount of tests like the key populations, yielding just a very thin line of positive cases. And you can imagine the millions being tested for premarital testing, however, we don't find any positive cases. Another determinant is that I mentioned the first box where only 12% are done among key populations, but also we have a big problem diagnosing people late. So over almost 30% or 40% recently of people diagnosed in the region are diagnosed with their CD4 level less than 200, and that has an impact on the outcomes of treatment, of course, and contributes to the increasing death, plus increasing incidence because they are undiagnosed and unknowingly probably contributing to transmission of disease. So another determinant of why we are not doing so well, countries effectively have been trying to increase their testing and to increase the number of persons diagnosed or the case identification. And that was an annual increase of 1 to 2%, which is not in line with the increase that we have in the epidemic. And therefore, again, the epidemic is running and we're running behind it and not catching up with it. Also, we can see that the years of 2019 and 2020, there had been a decline in the number of tests conducted. And this is also explained by the COVID and the reduction in or interruption of services due to COVID. So to summarize those contributions to increasing incidence and increasing deaths is that testing is very much medicalized and very much centralized in big labs. If community organizations are allowed to test, there's always a need to go to a lab to confirm the test and have it reported. New approaches to testing, such as self-testing, network-based testing, community-based testing, are not rolled out in the region. So only 3 countries have small-scale self-testing. We have complicated testing algorithms. Several countries are still relying on Western blot, although WHO is currently advising against Western blot. We used to not recommend it because it delays the return of the result. Now we're advising against, also because of the sensitivity of the test. Demand creation is also still limited to the old approaches of outreach, peer outreach, one-to-one, etc. And we haven't leveraged the new technologies that are available, such as digital platforms, social media, etc. And goes without saying, and this is something that we keep saying and we keep mentioning, and it becomes like almost redundant to repeat it, but it is a huge factor affecting our response, which is stigma and discrimination and the legal barriers to care. Now we come to HIV treatment. You see also the treatment coverage. Currently only 27% are on treatment in the region. 27% of the estimated people living with HIV. We have seen a great increase from 2010 until last year in the number of people on treatment, but this is not contributing to increasing the coverage substantially because of the growing epidemic. And again, we see that high-income countries have high coverage of treatment, while low-income countries, where the bigger burden is, they have very low coverage of treatment. Also, access to ensuring the quality of care is hindered. So only 38% of people living with HIV on treatment had access to CD4 in 2018, and 32% had access in 2019. We see also viral load testing not available for everyone. This is only at least once a year. Viral load testing, almost half did not get a test, and among those, 87% are virally suppressed. So we're close to the third 90, but not there yet. Also, retention in treatment is suboptimal in many countries, and the same reasons of stigma, of complicated pathways, etc., are contributing to weak retention in treatment, and this is also varied by country. So the higher income, more the retention; the less income, less retention. And we have countries in emergencies such as Syria, where retention in care now is only 37%. So within a year, they lose 70% of those, or 60% of those who were put on treatment.
Dr. Jumana, 1 minute, please. Dr. Jumana.
No?
Here.
Sorry.
You have 1 minute.
Okay, sure. So Lebanon and Morocco are closest to closing the 90-90 gap. Now we're looking at the 95-95-95 gap. We are yet to see how we will reach it. And also, we have had countries reporting stock out of treatment, which is very dangerous and contributing to some resistance. So also, you see here that the majority of patients in the region are on first-line treatment, and this is not necessarily a good thing, but also the capacity to detect when people should be switched to second line and third line could be hindered, and also death without switching to advanced lines of treatment are happening. Also here you see with the practices, only 13% of people living with HIV in the region are receiving optimized treatment as per the latest guidelines. So in summary, we are saying there is insufficient testing among key populations, there is slow transition to optimized treatment, and there is varied country implementation. To say that the key attributes to these findings are limited acknowledgement of the burden of disease and the size of key populations, slow translation of policy into implementation, attrition rate, suboptimal treatment, and patient literacy, stigma and discrimination, gender disparities in access to care, and in many cases, weak monitoring and evaluation. So the way forward is what we are now developing, and next week we will have a consultation with member states on the regional action plan for the implementation of the global health sector strategy. And this looks at a paradigm shift to test key populations and optimize services, address the barriers to scaling up, strengthening civil society and NGOs to alleviate stigma, and to strengthen strategic information, that is surveillance, monitoring, and evaluation, and to direct the resources to high-impact interventions. So we have adopted the 5 strategic directions of the global health sector strategy: high-quality, evidence-based, people-centered services, leveraging systems, using data to drive decisions, empowering communities, and using innovations. And for those,
we have to stop here, please.
Okay, for those, these are the set of actions or the groups of actions that are recommended. Thank you.
So sorry again for the shortage of time. We have to move to the third presentation. Thank you very much, Dr. Jumana. Our third speaker, Dr. Jamila Salman, who does not need introduction to this audience, and she will be telling us about defining healthy outcomes in HIV. So, Dr.
Thank you so much, Dr. Leila. Thank you all for being here. Good morning, everybody. I think, the lecture I'm actually replacing Dr. Shireen because she has delayed flight, but she will give her presentation in the second session, inshallah. So, in regards to my presentation, I think after the beautiful presentation that we saw from the previous speaker,
you have 15 minutes.
Okay, no worry, dear. We'll go with 15 minutes. See? That's a challenge. Okay. So what I'm going to talk about in this lecture, and make it really easy and simple, and we try to finish it shorter than the 20 minutes, what's probably important for each of you here. I think at this stage, when we talk about HIV, we are not talking only about starting medication, which we call it antiretroviral medication, and making the patient virally suppressed and they can live normally. We are looking for a quality of care, where we have to go from here. So when we talk, it's not only viral suppression, it's really a quality of care, a quality. The patient should be the center of all the services we do. We have to modify it and update it with our patient. So, our patients are getting older, so I think we should not really feel bad getting older, and we have more patients above. And I'm not talking about above 65, we have above 40 and 50, and that aging process comes with diseases, comes with comorbidities, medication, which puts more stress in how we are dealing with the HIV patients. So internationally, people with HIV are living longer because we have the perfect medication that really can make them live longer. But we have to understand that we have to look on the impact of aging in patients with HIV on the aging process, how to put the optimal approach. And I think it was really beautifully mentioned in the previous presentation. We are talking about the fourth 90. In the HIV field, we've been talking for a long time about 90, the first 90, the second, and the third. The fourth 90 is not only viral suppression and engagement and link to care, it's the quality of life. And now you hear it's not 90, we are raising the bar, we are talking about 95. So that's what we are looking for all in the field of HIV. Looking at why we talk about quality. If you want to maintain quality for HIV patient as a chronic patient, you have to concentrate on several factors. First, you have to concentrate in prevention, and you will be able, if you have a good access, testing for HIV, and you heard several examples. There are rapid tests, community testing, mobile testing that you can get it better, and also access. Treatment, access, and good quality. Advanced care package, it's a package. Our HIV patient, they have a lot of things to care about, not only the medication, and you have to retain them in care. That's the ultimate goal, where you'll be able to decrease the impact of the HIV patients on all of it. WHO, I think we hear Dr. Jumana from the WHO office, they were talking all the time about certain parameter, how to improve the quality of care. It's not, as I said, medication. So whatever you are doing, how we define quality health service, it should be effective, safe, people-centered, timely, equitable, this is very important, integrated, efficient. So whatever your background, you don't need to be an ID to care or have a relation to HIV patient. That's very important. And this is the, the steps that WHO talk about, where we have to start from individuals. Community should be involved. Institution at any treatment facility. You have to have regional and national plan for HIV if you are planning and want to get better. What are the enablers? How to make it better? It's not one, as I said, it's not ID physicians, not pharmacists, it's not, it has to be everybody. You have to have a good quality plan for HIV. And we have, for example, in most of the GCC country, we have a strategic plan for HIV. quality assurance and improvement integrated within the service, define package, and we'll talk about this package, and community engagement. It's really crucial. So you have to understand what the patient wants. It's a people-centered care. It's not about us, it's about the patient, what they want, and how we can really move forward. So, as we said, it's not only we have a good system to give medication, we have to see faster way, good appointment system, they are not delayed, and how we deal as healthcare worker with this patient. Stigma is still a major impact. Whether we want to say it or not, you as healthcare worker, still we have this stigma in the healthcare facilities. So, why with aging? I'm saying aging, we're not talking about elderly. We have, a separate lecture about it. As you said, probably saw in the previous, the percentage in the Middle East, we are not high, but the percentage of above 50 is increasing. So if you look for UNAIDS report in 2014, 13% are above 50 years. In 2018, 51% of patients living with HIV in the United States above 51. Netherlands, they are predicting by 2030 more than 70% about 50. So it's good. We have good medication. We are moving forward, but it's interacting with the service that we are doing for the patient. A lot of issues. Just age add more stress. So race, migration, culture, socioeconomic status, gender identity, and sexual orientation. It's not easy, but with aging, actually, it gets really worse. So, there's one survey that has been conducted nationwide in the United States to look about the effect of aging with HIV. And what they found, these are the major findings for provider and patient. Still discrimination for us is there. And probably if you're working, we still hear, no, he's HIV, why we should do surgery, or he's HIV, why he have to go to the ICU. That should not happen anymore. Loneliness, and I think the impact of COVID-19 make it more clear actually. Substance abuse is there. They don't need to be an IV drug user before getting HIV, but it will be there probably if they have any psychosocial issue. HIV provider, they should treat patient holistic approach. Now in HIV field, I know that most of us who are dealing with HIV patient, we know that we are a kind of family physician because we have to look for everything. Their diabetes, hypertension, hyperlipidemia, weight gain. We have to look at all of this, vaccination. So we are the primary care and we have to look at it. For the patient really is not easy. What's not easy? If they are insured, what kind of service you have in the country, access to the service, social isolation, it's very important because HIV patients, they get isolated by themselves, they isolate themselves from the community once they know that's from themselves. And again, the way, if the community know that they are HIV, they will be isolated. So it's not easy. And telemedicine and telehealth, where we have a good experience with HIV. So to understand how to keep our patient healthy, we have to know the interaction. It's usually between the host, who is this patient, virus impacting immune system, and the effect of HIV medication. Complicated? Yeah, it's not. So if I want to have a healthy aging for my patient, HIV can affect all of this. The life of the patient, the immune system, work capacity, no control, individual depression and anxiety. So we have to prevent all of this to be able to have a successful aging. The other thing which is important for all of you here, whether you are a cardiologist, primary care physician, endocrinologist, you will see the process. HIV infection affect the immune system, the thymic regulation in our body. You can be predisposed to co-infection. The HIV virus replication in the body is not easy. You start ART, antiretroviral medication, and it has worse. So another co-infection, CMV, mucosal, and inflammatory mediator, which really leads to all of this. So they have more malignancy, more cardiovascular risk, inflammation. So this is what gets their life not easy. So what we see, more of cardiovascular diseases, cancer, lymphoma, diabetes, osteoporosis, that we have to look at them when we see the patient in the clinic, and that's because of the immune response. How we tackle it, we'll not go into details. Number one is to give them the antiretroviral in timely manner and do something else. What's this something else? As I said, they have a lot of issues. Late diagnosis is a major, but polypharmacy, multi-morbidity, cognitive impairment, psychosocial issue. I'll give you just one, about each group or each disease, something you can do, each of us can do. So if we start with ladies, that's just, I'll start with ladies, So with women, they have more impact in the way they live because they have to deal with menopause, cognitive, stigma. It's more, believe me, it's worse with female than male. Lack of self-care, isolation, sexuality, frailty, BMD, osteoporosis, it's more with female. And that's why we have special instruction for ladies who have HIV and going to, antenatal care, all the package. If you are an OBGYN, you know how that's go and how much we give care for our pregnant ladies. Adolescents, it's worse. Really, it's worse. If you have an HIV patient who's 14 or 15, it's really bad. And that's basically for the psychosocial and the challenges they have in the health system. Their response to treatment, their compliance is not as the adult. So that's why you have to look for more. The stigma affects them more. They're a teenager, the loneliness, the social impact, their peer pressure. It's not easy actually to deal with. So what happened, and this is very important graph to look at, is if you look at the red one, which is 10 to 19, the retention in care over 1 year, the worse in the teenager. So you lose their follow-up. You have to really address it in your institution. A lot of impact in adolescents, and we are seeing adolescents. So we are not far from seeing 14 and 15 and 16 that they get HIV. It's how to deal with it and how to make sure they receive their treatment. Mental health is very important. People with aging, and even whether adolescents or adults, or elderly, they have high rate of depression, social isolation, loneliness, and lower socioeconomic status.
Dr. Jamila, 4 minutes.
Sure. And with geriatric population, it's really worse. Multimorbidity. They age, they have other diseases. And as I said, it's not really, I'm talking about 60 or 70 years old. Even above 40, if you look for HIV negative versus HIV positive, they have more comorbid disease per age. What does it mean for us? These are the diseases, and I'm sure you see them in the clinic, and probably you can highlight them, the most common that we see. The problem for these risk factors affect HIV, and HIV affect them. They really don't work. Actually, they conspire to make it worse. Polypharmacy, if you have multimorbidity, you will be in a lot of medication. And that's where a lot of problem with adherence, drug interaction, and a drug disease side effect. It has to be addressed. We'll not go through the drug interaction, but we adjust it to renal and liver. For cardiovascular, we have guidelines how to deal with cardiovascular risk among HIV. That's important. Related to cardiovascular, weight gain. It's very important in the HIV population to address it, exercise and diet, because it impacts them, and exercise promotion. Smoking is higher in HIV patient, and the rate of quitting smoking is lower, so they stay longer and it affects the cardiovascular system. I'll skip. The nutrition is very important, and I'll go to the final, where vaccination is very important. This is how we maintain it. So the guidelines are there, how to maintain the health of our HIV patient, basic screening, look for comorbidities, treat them very well. With aging, we have the same, and probably looking for cancer screening, but usually the age is different because, as we said, it conspires with the risk factor. So to get it better for our HIV patient, you need a clinical expertise, you need structure to provide the care, and it has to be practical. And the last message for you, when we talk about stigma, for you as healthcare worker, we are doing it. I know it's it's not in purpose, but prejudice about that, stereotyping this patient, and discrimination. If one thing you get out from these 2 days conference really is we have to stop this stigma against HIV to be able to provide the best quality of care we can provide for them. And thank you so much.
Thank you, Dr. Jamila. Perfect time management. So our last speaker for this session is Dr. Jack Makhbat. Dr. Jack is a senior HIV consultant and for the last 3 years has been heavily involved in the management of COVID-19 infection. So he will tell us about how to optimally manage HIV and COVID-19. Thank you, Doctor.
Thank you very much. And thank you for the organizers to invite me here. It's a pleasure to be in Bahrain again. And assalamu alaikum. Can we have the first slide, please? Thank you. No slides. Well, Dr. Salman, you made it a very difficult act to follow, and your presentation was outstanding as usual. Okay. Can we move? Should I move it? Okay. I have something else here on the computer. I have something else. Anyway, I don't know how to follow. So this is my outline. So I will start talking about the HIV impact on COVID, then the interactions between HIV and COVID, and the impact of COVID on HIV care and management, and some conclusions. So basically, the first series that was presented was a series in Spain that demonstrated that approximately, although they had 5 out of 543 patients who required hospitalization, none of these 5 patients died and 2 needed intensive care units. So the rate of hospitalization in persons with HIV who caught COVID was very, very limited. So this is a very important presentation, the first study. Can I have my slides here, because it's very difficult for me to move back and forth. So if we look at this review of persons living with HIV, the most common symptoms are fever, cough, and dyspnea, which is basically the usual symptoms that we see in everybody who has COVID. Okay, and the less common symptoms, headaches, myalgia, sore throat, etc. So basically, the presentations of COVID in persons with HIV is very similar to the presentation in patients. Thank you. It's very similar to the presentation of patients with no HIV. And this is not moving neither. Okay. Next. So, in persons living with HIV, again, in this review that was done in the United States, approximately the COVID was reported as mild to moderate in approximately 2/3 of the persons, with only it was severe in approximately 20% of the individuals, and 16% were admitted to the intensive care. However, something that is very important. First, yes, a lot of people were on antiretroviral therapy, so they were controlled as far as the virus, but 39% had hypertension, obesity, and hyperlipidemia, as was demonstrated by Dr. Salman earlier. A lot of comorbidities were present in these patients. So we have to correct for these comorbidities before we move on to try to understand what is the impact. But the difference here between the Spanish study and this study is clear. So basically, it's not following. The impact of HIV on COVID-19 in the United States, in this study as well, in this very large study of approximately 21,522, 28 individuals, 220 of them had HIV. The outcome, there were no significant associations between positive status and in-hospital COVID-19 related outcomes. So let's move to the next slide, please. And in this particular, several studies that were reported in the United States, again, in the in Mass General Hospital and Mount Sinai Hospital, no differences in disease severity on admission or adverse outcomes with or without HIV. So far, we have several studies, but notice, almost all of these studies are done in high-income countries. So we are dealing with a very different and very select group and very high group of population with high-income countries. So let us also look at studies done in sub-Saharan Africa. Next slide. Thank you. This is, let's move. Okay, in this study, also in Spain, the HIV did not increase the susceptibility to SARS-CoV-2. This is, I think I have passed this slide already. Next. Okay, so if we look at the interplay between HIV and COVID, the impact of HIV on the susceptibility to SARS-CoV-2, persons living with HIV were generally not more susceptible to COVID-19 by virtue of HIV infection alone. However, we have to consider the other risk factors. I want you to remember that. Other risk factors are extraordinarily important in impacting the risk of persons living with HIV risks to COVID. For example, the congregate living situations, the poverty, and the increasing rates of smoking, as was demonstrated by Dr. Salman earlier, chronic lung disease, diabetes, dyslipidemia, obesity. So all of these impact very much the susceptibility and the risk of COVID-19. We all know that these are extraordinarily important risk factors for the severity of COVID-19. So the impact on severity of the end outcome were at increased risk in countries, in high-income countries, and there is a high mortality due to COVID-19 in a large cohort in South Africa. Now, let us try to understand what happened in South Africa. Next, please. So, in this is again, in this particular study, as was shown here, you see that in this particular populations of 49,000 individuals, four of them had HIV. The survival probability was very similar between those who had HIV and those who did not have HIV. So in this very large study, of course, after matching for body mass index, diabetes, hypertension, chronic lung disease, so all of these important comorbidities that impact the survival of COVID-19, we see that there is absolutely no difference as far as survival. The next slide. However, next slide. Okay. However, if we look at individuals where the CD4 count, if we look at the CD4 count in individual who had very low CD4, less than 200, we see that the survival is impacted as those who had a CD4 over 500. So this is extraordinarily important to realize the impact of the immune suppression on survival. Next slide. So in a study we have done in our group in Beirut, we reviewed about, next, ما بيمشي. Okay. So in a study we have done in about 200 individuals by a telephone call, we called our patients, we sampled 200 persons haphazardly, and we asked them whether they contracted COVID-19 during the first 1 year and a half, and we found out that approximately 1/4 of them had COVID-19. Next. Next. Okay. The symptoms duration were very, very similar. Do not forget, this is a period where we had the Delta wave. This was at the time of the Delta wave, because this was in the late 2020, early 2021. So the Delta wave, we had approximately, the largest majority had a disease symptom period less than 10 days. And next slide. And we notice that only 4% were hospitalized. So this is very much similar, if you wish, to the majority of people. But do not forget, the largest majority of these individuals are young. So they are less than 50 years of age, not similar to the population presented by Dr. Salman. And only 2 required oxygenation. One of them only was not, one was hospitalized, okay? And none of them required intensive care unit, none of them deceased. So could could persons living with HIV have a worse outcome due to COVID-19? Yeah, theoretically, yes, particularly those with a low CD4 count, and do not forget the impact of the comorbidities. Okay, and since particularly in countries, in high-income countries, the largest majority of persons living with HIV are now aged more than 50. So we need to look into that. Could persons living with HIV have a better outcome? Now that this is important. Could they have a better outcome with HIV? Well, theoretically, yes. Because technically, what causes the problem with COVID? The inflammatory response. Well, persons living with HIV, particularly those who are supposedly a little bit immunosuppressed, may not have an immunological response. So this is something that is important. So there is a suppression of inflammation. I mean, actually, don't we give steroids when we have a severe COVID? Well, it's the same thing with HIV. It causes a significant immunosuppression, and therefore it might decrease the inflammatory response. So this is theoretical, okay? Of course, we need to be concerned also about the use of antiretrovirals. Tenofovir has clearly, in vitro at least, it is structurally similar to remdesivir, but tenofovir, which is, as you know, very frequently used in the management of HIV, has an effect in vitro that is inhibitory to SARS-CoV-2. It was talked a lot about protease inhibitors. They are not effective in vivo, certainly. And, well, something that is important that I have noticed, I don't know if you have noticed that in your patient population, persons living with HIV, during the big waves of COVID-19 were scared. They stayed at home. They did not go out. They frequently did not intermix with a lot of people. So that could be a reason, by social distancing themselves, is that they decrease the impact of COVID-19. That could be a possibility. So technically, persons living with HIV may have a better outcome during the COVID pandemic. Next.
دكتور مخبط 3 minutes
3 minutes?
إذا ممكن.
Well, okay, I'm going to move as fast as possible, although with my slides, I'm having some problems. Now, I want you to focus on this part of the slide. This is a very busy one, but just look at that, okay? Again, to demonstrate that individuals who are receiving tenofovir, TDF, not TAF, TDF, basically have no ICU admission, while those who were receiving TAF, abacavir, or other regimens did have ICU admission. So this is one thing to add to the next slide. So basically, the major outcomes is that individuals, the percentage of death were similar, intensive care admission, no significant difference, mechanical ventilation, composite, etc., and basically discharge from the hospital, all individuals were very similar in this evaluation. Next slide. So in conclusion, in these studies, it appears that HIV does not increase the susceptibility to COVID-19 or its severe outcomes. There is no difference in incidence and no difference in severity. The impact is due to the comorbidities. Next, and to the immune suppression. Next. Okay, I would like to move. Next. Okay, what about the impact on HIV care? Next. Okay, so the pandemic's victims are actually those who are affected by the disruption of the healthcare systems. Next. So there is an interplay, there is a disruption of the key pillars of prevention of care in HIV, disruption of the healthcare system, increase of stigma, as was outlined by Dr. Hermes earlier, decreased access to antiretroviral therapy, worsening socioeconomic vulnerabilities. A lot of companies closed down, a lot of people lost their jobs. Okay, and of course, the first people who are kicked out of their job are those who are living with HIV. Worsening socioeconomic vulnerabilities, therefore, the loss of social services, food insecurity, substance use, marginal housing, etc., etc. So this is something that was already present in persons living with HIV that was clearly worsened because of the HIV, of the COVID pandemic. Next slide. So basically, there is a decreased access to HIV testing, decreased access to condoms, decreased access to PrEP, and decreased access to post-exposure prophylaxis. Next. So there is also a worsening of the adherence problems. People had difficulty to go to the center to pick up their medication. So they decreased and they started cutting short on the number of pills that they were taking. And they were skipping days, skipping doses. So this is a very, very important problem. The shortage of medications and supplies. Physicians and hospitals, we were all busy with COVID. We forgot about HIV, well, some of us. So I think this is important. The dedication of the healthcare workers and resources, okay? Everything went to COVID. HIV became a second line problem. And this is something that we should also focus upon. I think, what's going on?
Dr. Makhbat, 2 minutes.
Yes, but
Please. Yeah. Can
okay.
you move the slides, please,
Next.
because it's moving backward.
Next. Next. Okay. Next. Next. Okay. I just wanted to show you what the problems in Africa, the gains that we obtained after implementing antiretroviral therapy in Africa. There is a significant decrease in death, and this is the estimated loss of AIDS-related death could be lost because of COVID. Next slide. Next. Okay, so disruption of HIV testing, HIV monitoring, load, etc., etc. So all disruption of services that were due to COVID-19. Next. Okay, next. Now I just, wait. I just wanted to show you something here, is that if the additional COVID-19 death that could be interrupted, that could be increased because of COVID-19, people were saying, well, if we go to the centers, if we go to hospitals, we're going to catch COVID. Yes, that is true. There is a risk for that. However, the risk of dying from COVID, when they go to these centers, when they reach the HIV care centers, this is the risk. In several models, These are the risk factors. Here they are. Okay, you see the first three columns. The first three columns are here, and they demonstrate an increase in death due to COVID-19. However, the HIV-related death that could be prevented by seeking these care in these centers, look at the number of deaths, look at the number of HIV cases that could be prevented. So definitely, seeking care, seeking healthcare services for HIV should continue despite the presence of COVID. Next slide. So basically, I want to
Can we
move
go to
on.
summary, Dr.
Next,
Mahmoud,
please.
please?
Okay, one thing that is important is the impact on research. There is deviation of research from HIV to COVID-19, decreased funding for psychosocial research and support, and involvement of all scientists and physicians with COVID. Next. So in summary, the incidence of persons living with HIV is similar to the general population. There is no clear evidence for more severe disease in persons living with HIV. Persons living with HIV with a low CD4 count and comorbidities will have poorer outcome. Ensure the continuum of HIV care and HIV services during lockdown and isolation. Switching ARVs are not recommended, and teleconsultation and telepharmacies, and we need to ensure the continuity of antiretroviral supplies. So in conclusion, make sure that the healthcare system, supply chains, and communities are very important in resource-limited settings. Support those that are most vulnerable. Make sure that social distancing continues. Limit the number of times people living with HIV visit a health facility. However, we should not discontinue the healthcare services related to HIV. We need to support appropriate triaging and ensure sufficient supply of antiretroviral therapy. And thank you very much.
Yeah, okay. Thank you very much, Dr. Jack. I'd like to thank all the speakers for excellent up-to-date information. Thank the audience for active listening, and we'll be stopping here. Opening ceremony will be at 10 o'clock. Thank you very much.
بسم الله الرحمن الرحيم. معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة، سعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة، أصحاب المعالي والسعادة، السيدات والسادة، حضورنا الكرام، السلام عليكم ورحمة الله وبركاته. يسعدنا أن نرحب بكم أجمل ترحيب في انطلاق أعمال مؤتمر البحرين الدولي الأول لمرض نقص المناعة المكتسبة، الذي تستضيفه المملكة على مدار يومي 22 و 23 سبتمبر 2022، ويجسد ما تتمتع به مملكة البحرين من إمكانيات عالية في احتضان المؤتمرات الدولية العالمية في العهد الزاهر لحضرة صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك البحرين المعظم حفظه الله ورعاه، واهتمام ومساندة صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء حفظه الله ورعاه. الحضور الكريم، لا شك أن مملكة البحرين تولي اهتماماً بالغاً في القطاع الطبي الذي سجل محطات رائدة طوال الفترات الماضية، ومن أبرزها الخطوات والرؤية العالمية التي اتخذتها مملكة البحرين في التصدي لفيروس كورونا كوفيد-19، حتى ضربت البحرين أروع الأمثلة في التصدي لهذا الفيروس، وأصبحت المملكة محط أنظار العالم في التدابير والخطوات التي اتخذتها لمحاربة كورونا. إن استضافة مملكة البحرين لمؤتمر البحرين الدولي الأول لمرض نقص المناعة المكتسبة سيسهم في تحقيق أهداف عديدة لكافة الدول في ظل محاربة الدول لمرض الإيدز. ولا شك أن رعاية معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة سيساهم في تحقيق الأهداف المرجوة. Your Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, Chairman of the Supreme Council of Health. Your Excellency Dr. Jalila bin Sayyid Jawad Hassan, Health Minister. Your Excellencies, ladies and gentlemen, warm greetings. We take this opportunity to welcome you all on the inauguration day of the Bahrain International AIDS Conference, which is hosted by the Kingdom of Bahrain on the 22nd and 23rd of September. The event embodies Bahrain's high and advanced capabilities, embracing major international events in the era of His Majesty King Hamad bin Isa Al Khalifa, the King of the Kingdom of Bahrain, and in light of the care and support of His Royal Highness Prince Salman bin Hamad Al Khalifa, Crown Prince and Prime Minister. Our distinguished guests, undoubtedly, Bahrain is paying close attention to the medical sector, which has accomplished remarkable achievements in the past period. Most notably, the kingdom's bold steps and the global vision it adopted in facing the coronavirus pandemic, COVID-19. Through such vision and steps, the kingdom has set the greatest of examples in tackling the virus, as Bahrain has become under the international limelight thanks to the precautions the country has taken in this matter. Hosting the first edition of this conference will contribute to meeting several goals of all countries as we continue our fight against AIDS. To have the generous patronage of His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa will enable us to reach the objective set for this event. أما الآن فليتفضل معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة لإلقاء كلمة بمناسبة الافتتاح. Please, Your Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, give your speech on the occasion of the opening of the conference.
بسم الله الرحمن الرحيم. دكتورة جليلة، الأخ عبد الوهاب محمد، الدكتور أحمد، الحضور الكرام، أصحاب المعالي والسعادة والسيدات والسادة الخبراء المحاضرين والمتحدثين والمشاركين في مؤتمر البحرين الدولي لنقص المناعة المكتسبة، السلام عليكم ورحمة الله وبركاته. يشرفني أن يكون تجمعنا اليوم تحت قبة واحدة عنوانها مواصلة الازدهار بالقطاع الطبي والحرص على تقديم أفضل الخدمات الطبية للمواطنين والمقيمين على أرض مملكتنا الغالية، وتحقيق كامل للاستفادة من المؤتمر الكبير الذي يجسد رؤية وتطلعات حضرة صاحب الجلالة الملك حمد بن عيسى الخليفة ملك البلاد المعظم حفظه الله ورعاه، واهتمام ومساندة صاحب السمو الملكي الأمير سلمان بن حمد الخليفة ولي العهد رئيس مجلس الوزراء حفظه الله ورعاه. لا شك أن هذا المؤتمر يعتبر محطة مهمة لتأكيد ما تتمتع به البحرين من استضافة الفعاليات الطبية العالمية، ولها أهداف عديدة على القطاع الطبي لن تقتصر على مملكة البحرين فقط، وإنما ستشمل جميع الدول المشاركة، في ظل حرص المشاركين من الخبراء والمحاضرين على عكس تجاربهم على دولهم في القطاع الطبي، وبالتحديد مرض نقص المناعة المكتسبة. لقد اتخذت مملكة البحرين خطوات رائدة وما زالت ماضية في التطور والازدهار في القطاع الصحي، بعد أن ضربت أروع الأمثلة في الفترة الماضية عبر خطواتها المتقدمة في التعاطي والتعامل مع مختلف القضايا الطبية، خصوصاً وباء كورونا الذي شهد العالم للبحرين فيه بالسبق والتميز. الحفل الكريم أن البحرين اليوم تخطو خطوات طموحة في تغيير نظامها الصحي، والتي تجسد رؤى القيادة الرشيدة في وضع المواطن والمقيم على رأس الأولويات في القطاع الطبي، بتطبيق نظام الضمان الصحي والذي يغير جذرياً في طريقة تمويل المؤسسات الصحية وطريقة إدارتها. تم إصدار قانون الضمان الصحي في 2018، وعلى أساسه تكون صندوق الضمان، والذي سيكفل تمويل الخدمات الصحية للمواطنين بناء على قانون الضمان. بذلك تتحول المستشفيات الحكومية من الاعتماد على ميزانية محددة من الحكومة إلى التنافس فيما بينها لخدمة المواطنين والمقيمين في سوق تنافسية للمريض الحق في اختيار المستشفى الذي يرغب بالعلاج فيه. المنافسة قائمة بين جميع المستشفيات الحكومية والخاصة، وتم تحويل إدارة المستشفيات الحكومية إلى طريقة التسيير الذاتي، فالمستشفيات تعمل في سوق يعتمد دخلها على جودة الخدمات الطبية وكفاءة المستشفى في حسن استعمال موارده وقدرته على جذب العملاء في سوق تنافسية مفتوحة. وكذلك في الصحة الأولية، فإن نظام نصيب الفرد ونظام اختر طبيبك وحرية المواطن في اختيار طبيبه تتيح للمواطن الاختيار وتخلق المنافسة على اجتذاب العملاء وتقديم خدمة نوعية. إن الشعار القائم للخدمات الطبية هو الاستمرارية والتكامل لتقديم خدمة جيدة محورها المريض، تحقيقاً لرؤية البحرين 2030 في المجال الصحي. إننا نعمل لتحقيق رؤية البحرين 2030، وأهم نصوصها الرؤية تمكين جميع المواطنين والمقيمين في البحرين من الحصول على رعاية صحية ذات نوعية عالية تنافسية مستدامة تعطي المواطن حق الاختيار. المهمة تحويل البحرين إلى مركز رائد للطب الحديث والرعاية الصحية المتطورة، تستوفي جميع المؤسسات الصحية المعايير العالمية في تقديم خدماتها، توفير متطلبات الرعاية الصحية الجيدة مع ازدياد عدد السكان وزيادة معدل الأعمار. تعزيز الصحة بالتشجيع على اتباع الأسلوب المعيشي الصحيح، سهولة وسرعة حصول الجميع على الرعاية الجيدة في المكان المناسب، مراقبة أداء المنظومة الصحية ومكافأة الأداء المميز، والالتزام بأخلاق المهنة، تأهيل الأخصائيين المؤهلين في الرعاية الصحية. أخيراً، نتمنى لكم جميعاً التوفيق والنجاح وتحقيق كامل الأهداف من هذا المؤتمر، ونؤكد على دوركم البارز في ارتقاء القطاع الطبي واستمرار نهوضه بأفضل الطرق الحديثة، متمنين لكم دوام التوفيق والنجاح. والسلام عليكم ورحمة الله وبركاته.
كل الشكر والتقدير لمعالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة على هذه الكلمة المعبرة التي تجسد اهتمام المجلس الأعلى للصحة في مواصلة ارتقاء القطاع الطبي في مملكة البحرين وانعكاساته الإيجابية على كافة الدول. Thank you, Your Excellency, Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, for this valuable address, which reflects the keen interest of the Supreme Council of Health to elevate the medical sector in the Kingdom of Bahrain and its positive impact on all countries. والآن مع كلمة سعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة في مملكة البحرين لإلقاء كلمتها. And now allow me to invite Her Excellency Dr. Jalila bint Sayyid Jawad Hassan, the Minister of Health in the Kingdom of Bahrain, to deliver her remarks.
بسم الله الرحمن الرحيم. معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة الموقر، أصحاب المعالي والسعادة، السادة الأفاضل الخبراء والمحاضرين والمشاركين والزملاء في أعمال هذا المؤتمر، السلام عليكم ورحمة الله وبركاته. يسعدني أن أكون معكم اليوم في انطلاق أعمال مؤتمر البحرين الدولي الأول لنقص المناعة المكتسبة، والذي يعكس ما يحظى به القطاع الطبي في المملكة من اهتمام ودعم ومساندة تعزيزاً لدوره وتقدمه، وترسيخاً لمكانة مملكة البحرين المميزة كمركز إقليمي رائد على الخارطة الصحية لاستضافة أهم اللقاءات العلمية والحلقات والمنتديات الطبية المتخصصة والمؤتمرات الصحية التي تساهم في تدعيم وتبادل الخبرات العلمية والإكلينيكية ومواكبة المستجدات والدراسات والبحوث الطبية العالمية لصالح مقدمي الخدمات الصحية بمختلف القطاعات والمستفيدين منها. إخوتي وأخواتي، لقد سجلت مملكة البحرين محطات رائدة ودوراً بارزاً في المجال الصحي والطبي وفي توفير الخدمات التشخيصية والعلاجية والوقائية ذات الكفاءة والجودة العالية. كما أن تنظيم أعمال هذا المؤتمر يعتبر فرصة للتشجيع على إحراز المزيد من التقدم في هذا الإطار، وخصوصاً فيما يتعلق بالوقاية من المرض والتشخيص المبكر والعلاج والرعاية للمصابين والمتعايشين مع مرض نقص المناعة المكتسبة، وطرح العديد من التجارب الناجحة عبر مشاركة أفضل الكفاءات الطبية من مختلف دول العالم والاستفادة من الكوادر الوطنية في هذا الإطار. السيدات والسادة، إن مملكة البحرين تولي اهتماماً بالغاً للبرامج الوطنية الوقائية بصفة عامة ولبرنامج مرض نقص المناعة المكتسبة بصفة خاصة، كما وتحرص دائماً على توفير التمويل المستدام للتغطية الصحية الشاملة وضمان الالتزام بتأمين الحماية الاجتماعية اللازمة للمتعايشين مع هذا المرض. ولا شك أن التشريعات والإجراءات التي اتخذتها المملكة ساهمت بشكل كبير ومؤثر في وضع سياسات للحد من المرض والوقاية من مضاعفاته، من خلال السير قدماً في تنفيذ خطط واستراتيجيات فاعلة تضمن التكامل والتنسيق والشراكة المجتمعية بين البرامج الوطنية مع المرضى والمصابين في مختلف القطاعات. في الختام، نتمنى لجميع المشاركين والمنظمين لأعمال هذا الحدث الطبي البارز كل التوفيق والنجاح وصولاً إلى الغايات والتطلعات المنشودة من تنظيم هذا المؤتمر، مع تأكيدنا على أهمية مواصلة دعمكم للمساهمة في نجاح كافة البرامج والأهداف التي من شأنها تحقيق الارتقاء والتطوير والتغطية الصحية الشاملة واستدامة الخدمات بالقطاع الطبي في مملكة البحرين وفق الرؤية الاستراتيجية 2030 التي تحقق ما يهدفه المواطن المواطن والمقيم على أرض المملكة الحبيبة. ودمتم بصحة وعافية. شكرا.
كل الشكر والتقدير لسعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة على هذه الكلمة. Thank you, Your Excellency, Dr. Jalila bin Sayyid Jawad Hassan, Minister of Health, for this address. إننا نفتخر في مملكة البحرين بما حققه القطاع الطبي من إنجازات ومنجزات عديدة في الفترة الماضية، حتى أصبحت المملكة محط أنظار العالم. ولا شك أن مؤتمر البحرين الدولي لمرض نقص المناعة المكتسبة سيكون أحد المؤتمرات المهمة في تاريخ المملكة. لقد عملت اللجنة العلمية للمؤتمرات بشكل دؤوب طوال الفترة الماضية من أجل وضع التصورات الكاملة للمؤتمر وأهدافه، وهناك العديد من المحاور العلمية والعملية التي سيشهدها المؤتمر. We pride ourselves in the success of the medical sector in the past period, which have made the Kingdom of Bahrain in the focus of the world. Unquestionably, the first Bahrain International AIDS Conference will be one of the most important conferences in the history of the Kingdom. The scientific committee of the conference has worked tirelessly throughout the past period in order to develop the full perceptions of the event and its objectives. And there are many scientific and practical themes of the conference that will be covered and will be shed light upon. ونرحب الآن بالدكتورة جميلة سلمان رئيس المؤتمر لإلقاء كلمتها. Now allow me to invite Dr. Jamila Salman, President of the conference, to deliver her remarks.
بسم الله الرحمن الرحيم. معالي الفريق الطبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى إلى الصحة، سعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة الموقرة، أصحاب المعالي والسعادة، الحضور، الخبراء والمحاضرين والمشاركين في المؤتمر، السلام عليكم ورحمة الله وبركاته. يسعدني أن أرحب بكم جميعاً اليوم في اجتماعنا هنا لافتتاح المؤتمر الدولي الأول في مملكة البحرين لمرض نقص المناعة المكتسبة، حيث يعد من أهم المؤتمرات في المنطقة بالنسبة إلى هذا المرض. دعوني في البداية أؤكد لكم أن مملكة البحرين حرصت على تحقيق أهداف عديدة في الفترة الماضية من خلال التصدي لهذا المرض، من خلال الالتزام بالاستراتيجيات والغايات والخطط التي تخص حماية المتعايشين بهذا المرض وصون حقوقهم في الحصول على العلاج والعمل وتجريم التعامل معهم بأي صورة من صور التمييز، حيث لعب الدور البارز للمجلس الأعلى للصحة ووزارة الصحة في تحقيق هذه الأهداف من خلال اللجنة الوطنية للوقاية من مرض نقص المناعة المكتسبة، والعمل المستمر والجهود الكبيرة التي توليها الرعاية الصحية الثانوية والرعاية الصحية الأولية للمرضى المصابين. أهمية هذا المؤتمر تكمن في أنه يسلط الضوء على كل التحديات التي تمر بها منطقتنا العربية من تحديات في مواجهة هذا المرض، من تسجيل في بعض الدول زيادة في أعداد الحالات الجديدة، زيادة في عدد الوفيات، وقلة الاستجابة للعلاج. ومن جانب آخر راح نسلط الضوء على التجارب الناجحة في بعض الدول والتعامل مع مرض نقص المناعة المكتسبة وتبادل الخبرات. السيدات والسادة، سيكون هذا المؤتمر فرصة للتباحث لمواكبة أحدث المستجدات الطبية العالمية في مجال الوقاية من المرض، التشخيص والعلاج، وتقديم أفضل سبل الرعاية الصحية للمرضى المتعايشين مع مرض نقص المناعة المكتسبة، وتفعيل جميع الجهود من الوقاية في الرعاية الصحية الأولية إلى العلاج في الرعاية الصحية الثانوية والتشخيص المبكر وتقليل المضاعفات. الكثير من الجهود والإنجازات قد تم تحقيقها، ولكن هناك الكثير يجدر بنا فعله لتحقيق المزيد. الحضور الأفاضل، سنعمل يداً بيد من أجل تحقيق هذه الأهداف التي وضعت لهذا المؤتمر المهم وتحقيق المكاسب لمواصلة ازدهار القطاع الطبي في مملكة البحرين وفي منطقتنا. وتمنياتي للجميع بالتوفيق والنجاح. Give a short speech for the English speaking attendees. Your Excellency, Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, Chairman of the Council of Health. Your Excellency, Dr. Jalila bin Sayyid Jawad Hassan, Minister of Health. Honorable guests and distinguished speakers and attendees. A very good morning to all of you here. It's really my pleasure to welcome you all as we gather here in one place under a single roof to participate in this important conference. Let me start first by asserting that the Kingdom of Bahrain has ensured the realization of several objectives while combating this disease. The Kingdom has developed strategies to prevent and to treat for the treatment of patients living with HIV and preserving their rights to medical treatment and work, and criminalizing any kind of stigma against this patient. The Supreme Health Council has played an essential role in realizing these aforementioned objectives, and that reflects the continuous and effortless work by the National Committee for Prevention of HIV, led by Her Excellency the Minister, and the hard work and continuous work provided by secondary care and primary care for all of these patients. Ladies and gentlemen, the conference will serve as an opportunity for discussion, current and latest advances in the medical field in regarding to HIV disease, from prevention, diagnosis, and treatment. And there we will present the latest advance and research in relation to the disease. The importance of this conference, really, it will shed the light on the challenges that we face in our region in dealing with the HIV. From some of the countries where they have increased in the number of new cases, increased the number of deaths, and decreased the response to treatment. At the same time, we will share a lot of, a good experience and successful stories of treating these patients and taking care of them. We will navigate to mobilize our efforts to combat this disease at various levels, as I said, from primary care to secondary care to all levels of strategic planning and eliminating various forms of discrimination against individuals living with HIV. The objective remains the same at the core, with ultimate goal to give the best quality of care for our patients. Dear guests, we'll collaborate to realize the objective set for this conference for further development of the medical field dealing with HIV patients. Working together, each of us in your discipline, decision maker, administrations, physicians, nurses, pharmacists, hand in hand with the community to be able to give the best quality of care for our patient. A lot has been done, a lot of achievements were there, but really a lot of work is ahead of us, and we are up to the challenge. Wish you all the best in this conference and looking forward for a wonderful experience. Thank you so much.
كل الشكر والتقدير للدكتورة جميلة سلمان على كلمتها المعبرة. سوف يشهد المؤتمر مشاركة من نخبة من الخبراء والاستشاريين والعلماء من مختلف الدول الذين سيبحرون فيما وصل إليه العلم من التصدي لمرض نقص المناعة المكتسبة. All thanks and appreciation to Dr. Jamila for her outstanding speech. The conference will witness the participation of a group of experts, consultants, and scientists from different countries who will navigate the latest scientific developments in addressing AIDS. وحرصاً من اللجنة المنظمة على تقدير جهود الباحثين والخبراء، يتفضل الآن الفريق طبيب شيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة وسعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة بتقديم دروع تذكارية للمحاضرين في المؤتمر. And as part of the keenness of the organizing committee to appreciate the efforts of researchers and experts, allow me to invite His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa and Her Excellency Dr. Jalila bin Sayyid Jawad to present mementos to the lecturers of the conference. دكتورة جميلة سلمان رئيس المؤتمر. Dr. Jamila Salman, the President of the conference. With great appreciation to our guest speakers, please welcome Dr. Jacques Smokhbat. Dr. Mary Horgan. Dr. Batul Sulaiman Ali. Dr. Ali Amrani. Dr. Leila Debel. Dr. Faryal Khamis. Dr. Jihad Abdullah. Dr. Nasreen Rizq. Dr. Nasreen Rizq. Dr. Ahmed Al-Hissi. Dr. Nizar Bahbari. Dr. Mehdi Karkouri. Dr. Jalil Al-Nu'mani. Dr. Zakaria Al-Blushi. Dr. Hilal Al-Hashami. Dr. Nasreen Rizq. Dr. Osama Baksami. Dr. Jumana Hermes. Dr. Shireen Al-Fiqi. Dr. Adil Al-Sayyad. Dr. Besma Safar. Professor August Rizat. And we would like to appreciate our sponsors, our diamond sponsor, Gilead, our platinum sponsor, GSK, Alba, Temkeen, GPIC. الآن فليتقدم معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة بتقديم الدرع التذكاري لسعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة. والآن فليتقدم معالي الفريق طبيب شيخ محمد بن عبد الله آل خليفة تقديم الدرع التذكاري لسعادة الدكتورة جليلة السيد جواد حسن وزيرة الصحة. We are given the memento by Dr. Lieutenant, His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, to Her Excellency Dr. Jamila bint Sayyid Jawad, the Minister of Health. والآن فليتقدم معالي الفريق طبيب شيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة بتقديم الدرع التذكاري للدكتورة جميلة السلمان رئيس المؤتمر. أما الآن نقدم الدرع التذكاري للدكتور أمين عبد الله. والآن فلتتقدم سعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة بتقديم الدرع التذكاري لمعالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة. فليتقدم كل المكرمين. Will all the awarded speakers and guests come to the stage for a group photo, please?
تعال لا والله خلينا سبيكر
بنقول thank you أيضا. كل الشكر والتقدير لمعالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة وسعادة الدكتورة جليلة بنت السيد جواد. وفي نهاية حفلنا هذا نتمنى لجميع المشاركين التوفيق والنجاح في المؤتمر وتحقيق كافة الأهداف التي من شأنها مواصلة ارتقاء القطاع الطبي، وندعوكم الآن لزيارة المعرض المصاحب للمؤتمر. والسلام عليكم ورحمة الله وبركاته. All thanks and appreciation to His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa and Her Excellency Dr. Jalila bint Sayyid Jawad. In the end of our ceremony, we express our best wishes to all the participants in the conference and for it to reach its targets, which will carry positive effects on the medical sector. Now we invite you all to visit and view the exhibition accompanying the conference. Have a pleasant day. Thank you.
Hello? 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 Hello?
Nasreen, she. Okay. I have a contact on me as well, so I don't see the lines very much. So I'll just read the first two sentences. So I go down by half or quarter. It's okay, I can see well, but I have to come to reality. Assalamu alaikum. It will give me a great pleasure to start this session. We are already behind time, so kindly just get seated so we can start. My name is Farial Khamis, and I have my co-chair is Dr. Mary Hogan. Our first speaker is very known in the region, Dr. Nasreen Rizq, ID specialist and an HIV AIDS expert currently practicing in Beirut, Lebanon. She's an attending physician and an assistant at the Department of Internal Medicine, Faculty of Medicine at American University of Beirut. Dr. Rizq, you have 20 minutes, and we'll remind you 2 minutes before the end.
Oh, I look in the back. Okay. Well, we'll maybe wait a few minutes for everyone to come back in because it's a... Is that okay, Madam Chair, to wait a little? Thank you. Okay.
Give it a go, yeah.
All right. Well, good morning, and thank you. My name is Nasreen Rizq. I work at the American University of Beirut, where I teach infectious diseases, and I have a special interest in, as was mentioned, in HIV and AIDS care. I would like to thank first of all, the co-chairs and the organizers, specifically Dr. Jamida Salman, for her kind invitation. And I'm very pleased to be here with you to talk about this very important topic, that is HIV pre-exposure prophylaxis. And to start off, I have no relevant disclosures to this talk, financial disclosures to this talk here. And with this, within the next 20 minutes, I will try to answer these questions, some of those questions about PrEP, and maybe simplify it for our primary care provider colleagues who are present with us here today, and expand a little bit the limits and the barriers to prescribing PrEP to those most concerned. And to start with, I would like to just, with a show of hand, who's an infectious disease specialist here in the room with us? And who is a primary care provider or family medicine provider? Okay, and who is not a physician in this room? All right. Okay, well, again, this is a very important, I think it's timely to start talking about PrEP more, and again, try to simplify and answer those questions. The background, which groups would benefit most from PrEP, What evidence do we have to support the use of PrEP? And then some questions about toxicity, monitoring of toxicity, resistance, and the relation to STIs and what we can expect. And to start off, a quick background in epidemiology, just to show that around 1.5 to 2 million new infections of HIV occur globally every year. So despite huge efforts in controlling the epidemic, we still have, and I think in my opinion fail, because 2 million people are infected with HIV globally every year. And therefore, the strategy of the UNAIDS, and you'll hear more about the strategy from Dr. Fiki later on, but to includes a focus on prevention, testing, retention and care, and an anti-discriminatory program, and committing to respect, protection, and promotion of human rights and gender equality. So I think those are very important concepts we want to keep in mind when addressing this HIV care, prevention, and treatment and management in order to end the AIDS epidemic as a public health threat, as the UNAIDS says. And the fast-track targets, I'm not going to go over those, but again, if we hope to get to the 95 by 2030, we need to be doing more than treatment. And you saw earlier from the WHO slides, we really have a problem in this region in testing, retention and care, and I hope, again, to highlight today the role and the place of PrEP in this holistic approach to HIV management and control eventually, specifically for us. So despite millions of new infections, we really need to be doing something. And as a refresher for all of us, that HIV is transmitted through sex, through blood, from mother to child, and through occupational exposures. And we've done a lot since the early days of HIV, where they only had condoms in 1984 and 87 to control the epidemic. And we've been a long, long way from condom use as the only intervention or approach to HIV prevention. And so today, and we're very proud that we know a lot more about post-exposure prophylaxis. We use treatment as prevention, and you'll hear about that in a minute. We still continue to promote and use condoms for sex. We emphasize in certain settings on male circumcision. We counsel about harm reduction and device strategies for that. And we really treat sexually transmitted infections, and included among them should be HIV, and PrEP falls in that approach to a global, holistic approach to the management and prevention of sexually transmitted infections. You'll hear more about undetectable is untransmittable, how it falls in this list of as I said, we need more or other methods of prevention to stop and get those 2 million new infections to close to zero. So we need to be smart. We need to have simple, effective ways to addressing PrEP. And to start off, we're going to focus on HIV risk acquisition. And it's very clear that certain key populations are basically at an increased risk of acquiring HIV. And as you see here from a little old slide from 2019 and a special report from the UNAIDS, then if you're MSM, a person who injects drugs, or a sex worker, you're at 21 times more risk compared to other people in a society to contracting HIV. And if we focus on the MENA region, our region, you'll find that 95% of those new HIV infections occurring in the MENA are basically focused or occur among those key populations and their partners. So this is I think it's easy. If we're looking for simple, effective, smart, that's a very, very clear message that we really need to focus on specific groups in order to control the epidemic. Engaging other groups, and this is the approach, engaging in, again, taking into consideration all the other elements that were mentioned before, promoting sexual health and HIV prevention in a respectful approach, and promoting all the other human rights and other. Okay. And so what are the risk factors for HIV transmission? If we want to be smart and effective, we need to focus on the elements and recognize some of those factors that increase the risk, including multiple sexual partners, sharing needles or injection equipment, being in a relationship with an HIV positive person who's not on treatment, condomless sex, the presence of STIs, and substance use. Other factors would decrease the risk, such as abstinence, obviously, but that's very easy, and we all know impossible, right? I mean, impossible. It's impossible for people to abstain from sex. And that's a very important concept there, that sex is part of life, and this should be the basis of our approach to this PrEP specifically. We're not talking about punitive actions. We want to encourage people to continue and live their lives and to the fullest, and taking into consideration that, well, sexual practices are basically essential for a good mental health for all of us, and therefore, if HIV is a problem or is a risk, then we need to do everything around it to make that sexual experience safe for our patients, or our, primarily your patients. And this is a slide here that shows the estimated per act probability of sexually acquiring HIV, and you'll see that compared to blood-borne exposure, sexual exposure is definitely less risky, however, carries certain risk, and we're going to focus on that moving forward. So how did PrEP start? First of all, with another show of hand, how many have heard about PrEP here in this room before today? And how many would like to know more about PrEP? All right, great. So so PrEP stands for pre-exposure prophylaxis, and that means giving medications to people at an increased risk of acquiring HIV to prevent infection in the future. So it's a super simple concept. It's like compared to malaria prophylaxis. For those infectious disease or even family or primary care practitioners, if a patient comes to you going to, let's say, Zambia, or Nigeria, or traveling to a malaria endemic area, you will prescribe malaria prophylaxis. And this should be our approach and attitude to PrEP. Anybody at risk should be prescribed PrEP. And it's very simple because it will reduce HIV infection, and this has been proven. And I will not show you the millions of slides and studies that have shown that in a very clear way. But just to say that the efficacy is demonstrated in all sorts of human beings. Those heterosexual, homosexual people, everyone benefits from PrEP and reduces the risk of acquiring HIV infection through sex and needle sharing. So this is a timeline of the most important, I think, or some of the important points in a timeline of PrEP by being adopted in 2016 by the WHO, and in 2019, 120 countries around the world included PrEP in their national strategies to reducing HIV infection. However, we're here today and we're not doing or using PrEP as much as we should, especially in the MENA region, where you have a lot, well, the uptake of PrEP is very sad in our region. It's a very sad thing that in the world, millions of human beings are benefiting from this very simple and effective intervention to reduce the risk of acquiring HIV, and yet for us, we're not using it as we should, or teaching our colleagues around us and discussing this with our patients in the clinics. And so who should be prescribing PrEP? Technically everybody. The urologist who's treating a chlamydia infection should be aware that their patient, acquired chlamydia, urethritis, by having unprotected sex, and that is a risk for HIV infection. So the dermatologist who's treating HPV lesions on a penis or a vulva should also recognize and and maybe this should be our job to talking to them about integrating HIV prevention in their approach to treating the simple wart, because the wart is not a wart, is simply says that condomless sex occurred here and something can be done to prevent other STIs, including HIV. And I hope that, and I'm sure that all of you agree to this. So we should all be engaged in this. In order to make it simple, because there are a lot of myth around PrEP, and but this 6-step approach to it starts with discussing sexual health, and maybe that is an area where we're not very comfortable, but believe me, we all started somewhere. So with discussing this issues related to sex more and more with your patients, you will become more and more familiar with asking the right questions in a direct way and engaging that person in an approach to treating and taking care of their sexual health, because sexual health will, and all of health includes a healthy sexual health. So discussing sexual health, injection drug use also, indications for PrEP, recognizing them, keeping the groups we mentioned, but basically anyone who's having condomless sex with multiple partners or injecting drugs. Assessment of the current HIV infection should be step number 3, and that's super important. And then checking other labs, prescribing PrEP, and then monitoring patients. So 6 steps. And if you want, I can keep the slide for you to share later on, because it's just as simple as 1, 2, 3, 4, 5, and 6. And therefore, 1 is about discussing sexual health, and that's a comprehensive thing. And as I said, the more you do it, the more comfortable you will be. And that should not be, and we're healthcare providers, most of us here in this room are physicians, so that should not be a problem for us. Pretty much as you discussed diabetes and diet and hypertension, this again should be part of what we do every single day, what you do every single day, because there is a huge gap to cover. And if we don't do it, no one else is going to do it. It is our job and our responsibility to educate our patients about their sexual health and approach it in a knowledgeable, I'm sure you all know the information. We should be all collectively doing a little bit or a lot more to focus on this. So how do you approach sexual health? You just ask simple questions. So sexually active, how many partners do you use condoms? Are they men, women, or both? And that's it. And you let the person talk, and you can ask some questions to clarify. And those are the only questions any practitioner needs to ask all of our patients at intake for any kind of visit, primary care visit or STI visit. And then who should be offered PrEP? Well, it's clear, everybody who's at risk. And who is a person at risk is a person who has multiple partners, they don't know their serostatus, condomless sex. Sometimes you'll find sexual couples who are serodiscordant if the partner is not on treatment, but we hope that everybody on HIV or infected with HIV will be on treatment, so treatment is prevention. And injection drug users, and specifically key populations, men who have sex with men, injection drug users, and female or male sex workers. And so recognize the risks. That's why step number 1 starts with that sexual health intake and those questions. And then you need to, if you've identified a patient, let's say a young man who has multiple sex with multiple men and sometimes does not use condoms for any reason, that is a group, that is an example, great example of someone who will benefit from PrEP. Correct? So you'll need to assessment for acute HIV infection by asking some questions and sending some tests, which I think you all know. Starting with the symptoms, you have fever, a sore throat. Now, a fever and a sore throat could mean COVID, could mean monkeypox today. So we need to also expand a little bit around those concepts, but going through a few questions to assess the risk. And the last, and a very important question, I think, when was your last unprotected sexual exposure, to place that individual, because you'll need probably a good 7 to 14-day window, correct, for seroconversion. So you really want to make sure that that individual is not within that window period before starting PrEP. And then talking and sending the right test again, and maybe you want to send an HIV serology or a PCR for that person who's coming and saying, you know, I had unprotected sex maybe 14 days ago and I have a sore throat. And that same individual who's concerned about seroconversion is the best candidate for PrEP. Because you all see a lot of men and women, or a lot more men than women, I think, in your clinics, coming afraid that they have HIV. So that person who's coming for screening and asking questions and worried about it is the perfect example of your target for PrEP. And that visit, they're coming to you to answer a question, do I have HIV? And they are freaking out. Well, that is exactly the best moment to hammer them with the knowledge and talking to them about PrEP to convince them that, well, today we'll do the tests and next time I'm going to bring you to discuss the results, discuss risk reduction, and discuss PrEP with ordering the correct tests, and this is a list that I think is pretty comprehensive of all the tests that should be sent before engaging, before starting PrEP. You want to make sure you know your patient's Hep B status and their
Nasreen,
HIV status.
You have 3 minutes left. 3 minutes left.
Okay. And then talking to them, and the next time when they come, let's say they are Hep B negative, HIV negative, and you're comfortable with that, then you talk to them about how to take PrEP. And PrEP is oral and injectable. I'm going to focus on the oral formulations because I don't think the injectables are available to us in this region yet. So it's daily use. And you have to know that if you're starting a man on PrEP today, it will take them daily PrEP, 1 pill per day. It will take them 7 days to become protected, to protect them from anal acquisition of HIV. For a woman, it will take 21 days to get to where they need to be for vaginal protection. And this is super important. You cannot pop a pill today and go have unprotected sex tonight, 1 pill, if you're a woman. Okay? And there are no on-demand, you've heard of on-demand PrEP, there are no on-demand PrEP formulations or regimen for women. So you start with daily for men and women, 7 days for men to become protected, 21 days for women to become protected. And there is a on-demand option for those men within 12 hours from sexual act. So this is an event-driven or on-demand PrEP, 211, 2 to 24 hours before sex, and then 1 pill after and 1 pill after, and they can stop, or they can continue with the daily PrEP if this is a person who has multiple partners, as I said, and multiple partners and not using condoms frequently for sex. And so the regimen, basically, the oral formulations are based on FTC tenofovir or FTC TAF, either one. And it's usually a pretty well-tolerated drug for tolerability, toxicity, monitor creatinine. Really, bone health is not an issue in healthy young men. You can keep an eye on that, but that should not be a reason not to start PrEP. I think the major barriers are us recognizing risk factors and being comfortable discussing those risks with patients rather than the osteopenia. And very little problems with the resistance around the world. We don't know about our region. What we know is that a lot of young men are ordering PrEP over the counter or buying it online, taking it without medical supervision. So in my opinion, that is more risky than anything else. And that's where our role should be to supervise and engage with them to understand the needs and basically address those needs in a comprehensive manner. So monitoring, you go back to the slide, and we talked about on-demand. So this is a holistic approach. This is a slide I think I got from the AIDS Education and Training Center. Integrating PrEP in comprehensive sexual health should really happen and start happening, especially we do need more of that. And adherence is key, so you really need to make sure your patient is taking PrEP as they should. I hear a lot from women who, again, pop
a pill and they think they're okay for tonight. It shouldn't happen. We should be spreading more awareness around us, making it more simple, more effective, and maybe us becoming more approachable to our patients by understanding their needs in a better way, rather than leaving our patients, again, alone to take medications without medical supervision, without the education, without the risk reduction that we could do in our clinics and our practices and this whole approach. So with this, I am going to conclude here, and thank you for your attention. Thanks.
Thank you very much, Dr. Nasreen, for a very comprehensive review of PrEP. And I'll give the mic now to my co-chair.
Thank you, Dr. Farrell. I'm delighted to introduce Mr. Bruce Richmond. Bruce is the founding executive director of Prevention Access Campaign, which promotes and really founded undetectable equals untransmissible. That's medically and scientifically accepted by the wider community globally. So I'm really looking forward to hearing Bruce's talk. Bruce will join us virtually. Thank you.
Thank you so much. I just want to check if you can see me okay. You can see slides.
We can see your slides.
Okay, great. Then I apologize that I can't be there in person, and very much appreciate this opportunity to talk about U equals U. It's a great honor. And I am looking forward to first starting off with defining what U equals U is. I hope folks know about U equals U already. It's still, it's been around for about 6 years, but I'll talk about the origin of it, why it's so important, and then show some of the endorsements of U equals U from the highest levels in the field, and then also show you some of the ways that U equals U is being communicated, and then some tips about how to communicate it, because we all should be communicating U equals U with our patients and clients. So first off, what is undetectable is untransmittable? It means that when a person living with HIV is on treatment and has an undetectable viral load, and for purposes of untransmittability, that's defined as under 200 copies. An undetectable viral load, I think as most of you know, really depends, the measurement depends on the country and the kind of tests and the region. So in some places it's 150, some places it's under 25 copies. Other places don't have enough sensitivity of the test to determine below 1,000, but the main number to realize is it's under 200 copies per milliliter, according to robust data, is untransmittable through sex. So U equals U. This came about with the Prevention Access Campaign, working with researchers to first build a global science-based consensus on U equals U. And shortly, I'll show you some of the organizations that are backing U equals U. And then to disseminate that consensus and advocate for treatment and care so that people living with HIV can stay healthy and prevent new transmission. So Prevention Access Campaign and our partners are working on these two goals right now, and that's why I'm very honored to be here today to disseminate this information and really call for treatment and care for all people living with HIV. This is the way that people with HIV will stay healthy. This is the way to prevent new transmissions, and this is the way to end the epidemic, along with PrEP, as you heard from the speaker earlier. So why is U equals U so important? Well, first and foremost, it improves the quality of life for people living with HIV. People with HIV can engage in sex and intimacy and even have babies without any fear of passing on HIV to their children. It reduces HIV stigma, which we know is one of the greatest barriers to ending HIV. With stigma in the community and clinics, people are worried about folks knowing their HIV status. They're reluctant to go to get tested for HIV or to get treatment or to stay engaged in care. So learning about U equals U reduces stigma, and it propels progress towards the 95-95 targets, as you heard about earlier. I'll show you some data that shows U equals U reduces anxiety associated with testing. And as you heard from the WHO earlier, there's a real problem with HIV testing in the region. It also is an incentive to start treatment and stay on treatment and stay engaged in care in order to get virally suppressed. So it really propels towards all three of the 95-95 targets. It's also a reason to support the modernization of discriminatory laws and practices. When people with HIV do not have rights to engage in full lives, they're less likely to stay and start on treatment, and that will and that really impedes our progress towards reducing new transmissions. So we really need to make sure people with HIV have full lives to stay healthy and prevent new transmissions. We can only do that if people with HIV have access to treatment, care, and diagnostics. So, as I mentioned earlier, there's data that shows that when people with HIV, people who are during testing outreach, if U equals U is a part of the education, then in this study from South Africa, men were almost 2 times, double the chance of being tested for HIV. So we're seeing this kind of U equals U education in testing outreach all over the world, in South Africa, in New York City, in Guatemala City. We've seen it in London, and it's a great idea in Dublin, Ireland. It's a really important way to reduce anxiety by including U equals U in HIV testing outreach. We're also seeing data proving that when patients with HIV are informed by their healthcare professionals about U equals U, they are more likely to report optimal overall health, mental health, sexual health, viral suppression rates, comfort sharing their HIV status with others, and better adherence. So it's really important and should be a standard of care for doctors to share U equals U with their patients, because it will impact these positive health outcomes. U equals U as a campaign is now in 105 countries. There are over 1,000 partner organizations that have signed on to U equals U, including research associations, health ministries, community-based organizations, private industry, and pharmaceutical partners to endorse this message. And as we look around the world and work with our partners in different continents, there's many different barriers to implementing U equals U, sharing U equals U. I want to just bring up some of those and how we address those. This could be a conference in itself, just going into all the barriers. Now, one, of course, is just misinformation. There's still a lot of outdated information about HIV transmission risks. You'll see websites that are still saying that when someone is undetectable, it will greatly reduce the risk. It won't actually. Many of these sites are still not clear about how HIV transmission actually it works and the realities of HIV today. So there's a tremendous amount of misinformation, which leads to stigma and lack of engagement in care. Some folks say that there is, feel they don't have the authority to talk about U equals U. And that's really important in countries to have the ministries of health and folks in leadership's positions to talk about U equals U, so others have that sense of authority to talk about it. We have endorsement at the highest levels of U equals U, the WHO to the CDC to UNAIDS. And then also paternalism. We see doctors making decisions for their patients about what information their patients can know about the benefits of treatment, about their own bodies. We see this in all different parts of the world. And it's really the right to a patient to have all information about treatment and prevention. And it's really an ethical practice to share this information. But I think we're seeing in many parts of the world that doctors have a sense of paternalism and especially in public health, making decisions for people instead of giving people the information to make decisions for themselves. And then finally, U equals U is still fairly new, even though it's based on over 20 years of robust data. The concept of it is still only about 6 years old. It was endorsed by the CDC 7 years ago. And so it's still innovation, and it's human nature to tendency to push back on innovation. So that's one thing that we come up against. We try to say, borrow confidence in the experts in HIV transmission risk, the WHO, the CDC, UNAIDS, PEPFAR are behind this science. And so when we're feeling concerned about sharing this information, we need to borrow confidence from the experts and think of the positive impacts and share it. So as I mentioned, the global endorsements of U equals U are widespread. It's widely accepted by the global medical and scientific community. The WHO has endorsed U equals U and included U equals U in their treatment guidelines. PEPFAR makes U equals U one of 16 minimum requirements of all 50 PEPFAR funded countries. So in order to get funding from PEPFAR, these 50 countries need to show evidence of U equals U education. PEPFAR calls U equals U part of highest priority for person-centered prevention and primary prevention, excuse me. And the CDC has unequivocally endorsed U equals U and their guidelines and all their social messaging and marketing materials. CDC has been behind it since 2017, globally and domestically, which is really important, as we know CDC has an impact on the public health throughout the world. The United Nations just recently endorsed U equals U and the UN Political Declaration on HIV and AIDS. Member states signed on to welcome the recent scientific evidence of U equals U and use it in anti-stigma messaging. The United States has officially endorsed U equals U and integrated it into their guidelines. And I'll just show a couple of other countries. Many countries have already integrated U equals U and include it in their guidelines, like in Brazil, also in Japan. And U equals U has been the focus of conferences over the last couple years. This was the most recent conference in India. U equals U was the cornerstone of the National Conference of the AIDS Society of India. And a major message was, we can end AIDS now if U equals U, or undetectables, untransmittable, becomes a reality for all persons living with HIV. This is a really important concept, that if people with HIV have the treatment and care that all people with HIV need to stay healthy, that this is the way that we can end the epidemic. This will stop new transmissions. It will increase the, reduce the burden of healthcare costs and increase and strengthen the economy, with people with HIV staying healthy, contributing to the economy and preventing new transmission. So it's important to focus on this at our conferences. Also, Russia had several conferences over the past few years with U equals U. And then recently I was in a conference in Dubai, and knew that Dr. Al-Saman, I want to just acknowledge her, thank her very much. I was able to meet her and hear her speak so brilliantly at this conference. It was said at that conference that U equals U is a war between ignorance and knowledge. And it's great to be here again today to speak about U equals U and moving towards sharing this knowledge. Ukraine has had national U equals U campaigns. Monaco, Canada, Zambia. This is the former president of Zambia in the U equals U shirt signing on Zambia to the campaign. Kenya signed on. Vietnam officially signed on. And so now I'm just going to show you some of the messaging. Some of this is just a little bit of fun to see how folks are communicating this around the world. So these are young people in Ireland, Vietnam, and Argentina. Now this is interesting. In Venezuela on the left, this is the oldest indigenous tribe in Venezuela, has an M equals M program. On the right, this is the first campaign
I had no idea.
Arabic from Lebanon. There are all sorts of ways that U equals U is being promoted, buses in Indonesia, Norway, and US. In China, there have already been 3 national U equals U and PrEP conferences, and 1 conference just on U equals U. And U equals U has been frequently in the top medical journals in the world. These are the 3 top medical journals: The Lancet, JAMA, New England Journal of Medicine. And now I'm just going to briefly go through some of the rules and the basic ways that we have found people are communicating U equals U around the world. So first, the guidelines for communicating U equals U. It's really very simple. Stay on your treatment, get your labs done, and stay connected to care. So this is really, it's not that complicated. Medicine only works if you take it. So we just talked to our patients about get your labs, you take your treatment, get your labs done, stay in care, and don't worry about it, and live your life. It's very exciting. And the way that we talk about U equals U and the words that we use really, really matter. So we need to be clear, we need to be confident, we need to be consistent, and we need to be conscious in the way that we talk about U equals U for it to really have an impact on people's lives. So we really want to avoid words on the left like extremely unlikely or helps prevent, words that open up that little window of risk. Because if you open up a little window of risk, that conveys to people that people with HIV are still dangerous. We are still a small bomb, but not a large bomb. So in a sense, you're just a little bit dangerous, but you're not a lot dangerous. And that's enough to continue the stigma. But we really can be clear now and say words like can't pass it on, can't transmit, zero risk, and 100% effective, even zero risk. We have Dr. Anthony Fauci talking about how important it is to say zero risk. Alison Roger saying this, who is the author of one of the seminal studies on transmission risk. The CDC has indicated U equals U is 100% effective for preventing HIV transmission. U equals U is the most effective prevention method. And the British HIV Association is encouraging people to say no risk or zero risk. So there are lots of different ways, and I can bring up many more different examples of very clear language. And don't say things like, I believe in U equals U, but just in case, use a condom or use PrEP. You really don't need to say that. That causes doubt. What we can say are condoms and PrEP are not clinically necessary to prevent HIV when someone has an undetectable viral load, but you still might want to consider condoms and or PrEP to prevent other STDs or pregnancy if the partner with HIV is struggling with adherence to their medication, and just for that added sense of security, but it's not medically necessary. U equals U, as long as the person is taking their medication, is a solid 100% effective prevention method. We also hear people say you're only as good as your last viral load test. But that's really a scary thing to say. That means that someone with HIV can be infectious at any time in between their tests, even if they're taking their medication. That's not true. If you're taking your medication as prescribed and you're getting your viral load tests, you really don't need to worry. The medicine is durable in between tests. You don't want to wait a year or 2 years to get your tests. You should be getting them regularly just in case there might be any kind of issues, but this is the way that you can monitor and make sure that you have a undetectable viral load. You don't need to worry in between tests. Also, sometimes folks will just say, oh, you never know, just that all around anxious word, nothing's impossible. But the truth is we do know, and we can say it's impossible. Be consistent. This is new information, so it needs to be heard repeatedly and over again from the right people and the credible sources. Use many different channels to get this out through social media, newsletters. Have a conversation at every opportunity that you can. We also need to be careful that not everyone can reach an undetectable viral load, whether it's social structural barriers that are preventing it, and that we need to use the public health argument to make sure that everyone has access to treatment and care. When people with HIV are able to get to undetectable, this is a massive public health benefit. This means that we'll reduce new transmissions. So let's leave no one behind. So what's next? Countries really need to—
You've got 2 minutes, Bruce.
Thank you. Into policies, strategies, and guidelines so people hear about U equals U from the top. Healthcare professionals, like we're doing today, need to be educated and to encourage to have dialogue with their patients at every opportunity. We need to promote U equals U clearly in all health communications and we need to strengthen access to HIV treatment and care so that all people with HIV will have the opportunity to get to U equals U, to stay healthy and prevent new transmission. You can visit us at preventionaccess.org. We have a lot of resources on U equals U, and we're here to help with all sorts of things, whether it's capacity building or bringing in people with HIV to help lead campaigns, engaging the community for innovation, activation, and input, advising on subject matter, informing research and priorities, and bringing in insights and findings from the front lines on U equals U around the world. So again, thank you so much. I really appreciate this opportunity. It's an honor. I wish I could be with you there today. My email is here if there are any questions or folks need any more support about U equals U. Thank you so much.
Thank you very much for a fantastic talk, Bruce, and for all your contacts there. I'm going to hand it back to...
Now it gives me a great pleasure to introduce our final speaker for this session, Dr. Shireen Al-Faqih. Dr. Shireen is a regional director for the Middle East and North Africa at UNAIDS. She is by training immunologist and she has a PhD as well in molecular immunology. She is also an author and a pioneer in many of the studies related to gender equalities in the Middle East and North Africa.
Assalamu alaikum. It's a great pleasure to be with you today, and I'd like to thank Dr. Sheikh bin Khalifa and Dr. Jamila and the organizers of the conference for this opportunity. I can say that at UNAIDS we're incredibly excited to see this level of interest and commitment to really engaging on what we've heard is a challenging topic for us in our region, but we are here to assist in really rising to this occasion. My presentation is a little bit out of sequence because I was supposed to speak earlier today, but we all know what the world of travel is like these days, so I arrived very early this morning, so I'm going to run through the slides quite quickly, but I'm very happy to have conversations over lunch and the rest of the conference. So let's see. Great. Just for those of you who may be less familiar with UNAIDS, we here in the Middle East and North Africa, we are based in Cairo. This is our regional center, but we cover 20 countries across our region, ranging from Morocco, Maghreb in the west over to Iraq in the east. We have country offices in 6 countries, and they're in red on this map. And we are what is called the joint program. So because HIV is very complex, the response is not just medical, it's legal, it's social, it's cultural. We bring together what are called the co-sponsor UN agencies. These are 11 other UN organizations who assist. We all come together to tackle HIV, and among them and our great partners are WHO, EMRO, and you've heard from my friend and colleague, Dr. Jumana, earlier today. Again, this is a very busy slide. All it's meant to show you is that it's actually now 40 years since the beginning of the HIV epidemic and the beginning of the HIV response. And that's a very busy timeline, which you'll see. All the slides I'm going to show you are available on the UNAIDS website. They're also translated into Arabic, which is very important for us to get the message out in our region. But I just want to show you that at the end of this, so tackling HIV is one of the Sustainable Development Goal targets, and it's target 3.3. And the commitment that countries around the world, including Bahrain, have signed on to is that to end the epidemics of HIV, malaria, and tuberculosis, and also neglected tropical diseases by 2030. Now, we're at 2022, we only have 8 years to go, and clearly there's a long road for us to travel. All the data I'm going to show you in the subsequent slides, and I'll try to keep it brief because I know many of the other speakers have presented this information, they all come from this report, In Danger. And this is what's called the Global AIDS Update. It's a report that comes out every year, and it gives us a picture of what's happening in HIV around the world, including in our region. If you'd like to access it, you can find it at our website, unaids.org. We have a website for our region, and all the material is available in Arabic there, and that's unaidsmena.org. And please follow us on Twitter and on Instagram because we give all the updates on HIV in our region that are coming from UNAIDS at UNAIDSmena. Okay, I'm going to run through this really quickly. You've heard these numbers. Today, 38.4 million people are living with HIV. The good news is that close to 30 million people are now accessing treatment. This is a huge increase. In 2010, only around 8 million people around the world had access to antiretroviral medication. That's a huge increase. I'm sure Jumana talked about the numbers, the estimates of numbers of people living with HIV in the region. Around a median estimate is 180,000. Okay, so here's the good news. So globally, thanks to all the advances in HIV science and HIV treatment and public health, we have seen a decline in new HIV infections since 1990. I mean, that is an impressive curve. The world in general is heading in the right direction, although not fast enough to be sure to reach the 2030 target. Here's the problem. Okay, so you've probably heard this time and again, we are in trouble. To put it, I'm just going to say this very bluntly. There is the impression in much of the world that we don't have a problem with HIV in the Middle East and North Africa because we are Arabs, we are Muslims, this is not our problem. It's our problem. And I'm going to show you these numbers because this shows you how big this problem is. Okay, so this is all the regions of the world, okay, and it's showing on the left-hand bar is the change in new infections over the past decade, from 2010 to about 2021. And so the black bars are the new infections, and the gray bars are the changes in mortality. So AIDS-related deaths. And this is in percent, okay? So if you look from Latin America onward to the end globally, so globally, the last set of columns on the right, we've seen a 31% decline in new infections and a 47% decline in AIDS-related deaths. This is very good news. Have a look at Middle East and North Africa. I mean, this is us, okay? We have seen a 33% rise in new infections over the past decade. That's the second worst showing in the world after Eastern Europe and Central Asia, which has a higher increase. And then if you look at the decline in our mortality, it's only 22%. Now that's better than increasing, but the fact is that it's about half of the global decline. So we're just not doing very well on HIV. As you know, I mean, just something very basic about the HIV we have in our region. You know, you've heard this already today, I'm sure. We have concentrated epidemics. 85% of our new infections are amongst key populations: men who have sex with men, people who inject drugs, female sex workers, prisoners. Increasingly, migrants and refugees are also considered to be a vulnerable population, and their sexual partners. Okay, now why are we doing not very well, frankly? Why are we seeing this rise in new infections when the rest of the world seems to be getting HIV under control? Well, again, I'm not sure if this data has been presented earlier, but it bears repeating. Okay, our big problem here is that we are doing really, really, really badly on testing and treatment. I mean, there's no other way to put this. We have some success stories in some countries in our region, but the reality is we are falling behind. So here, these bars in black, they show the people who are living with HIV who have been tested. They know they have HIV. In red are the people who are living with HIV who are on treatment. And in gray are the people who are living with HIV who are virally suppressed. Effectively, the treatment is working. All right, I mean, just where we're supposed to be is over on the right. Those are the 2025 targets, and those have been shown earlier. We're supposed to globally have 95% of people living with HIV know their status, 95% of the people living with HIV are on treatment, and 95% of these people, the treatment is working. Okay, I've got bad news for you. MENA, those are the colored bars in pink, blue, and green. So we only have 65% of people who are living with HIV who actually know they have HIV. We have only 50% of people living with HIV who are on treatment, and a really, not good 44% of people who are virally suppressed. Now, one of the issues about the numbers I've just shown you is that this is just the tip of the iceberg. Because of all the taboos and controls and constraints, to put it bluntly, because a lot of communities and countries have not wanted to talk about HIV for a very long time, we actually don't have very good epidemiology in our region. We simply don't know what's going on in a lot of countries because we don't test the populations that are most at risk because of criminalization and cultural constraints. So all this is just like, as I said, it's a tip of the iceberg. We could be in a much, much more serious situation, but it's serious so far from what we know. Okay. Just to also point out, those averages I showed about the 60, the 60 and the 50 and the 44, those are just that, averages. We have huge diversity in our region, so some countries are clearly doing better than others when it comes to testing and treatment. This is just the treatment rates. So here you see Qatar essentially has almost universal treatment of the people that they know have HIV. There could be many more who have HIV that are not being detected because of limitations in testing and the like. But if you go down to the bottom, I mean, Sudan, Yemen, Djibouti, even Tunisia, which is historically been at the forefront of our HIV response, there the HIV treatment rates, only 32% of people living with HIV are getting treatment. It simply isn't good enough. Oh, I'll skip over this slide. Now, why are we not doing well? Okay, so it's a complex set of factors, but to put it bluntly, the problem is stigma and discrimination. When people who are at risk or people who are living with HIV feel that they cannot come forward openly, or don't even know, frankly, because there's so little conversation about HIV and the risks, it's not a surprise that you're going to see high HIV rates. And this stigma and discrimination is everywhere. It's not just in our communities. I mean, I'm going to speak personally. My family are all physicians in Egypt, and I can tell you that some of them have attitudes about HIV, and they're all very highly trained, which are not terribly progressive. And so we really do need to open up this space and to really be informed and responsive to people who are living with HIV and those at risk if we're going to really get a grip on what is an emerging epidemic in our region. The other problem, it's related to the stigma and discrimination, or basically, there's no other way to say this, really, really unhelpful laws and policies, okay? Let's just take this forward. Okay. When you criminalize people who are at risk of HIV, or indeed people who are living with HIV, what you do is you fuel an HIV epidemic. It's as simple as that. And so here I'm going to show you these bars. These are some of the laws and policies around HIV. So let's take the columns on the left. In black are the numbers of countries around the world that have laws that, for example, criminalize HIV transmission, exposure, or non-disclosure. Okay, so 69 countries in the world have these laws that if you unintentionally pass HIV, it's against the law, and you can find yourself convicted and go to prison. 69 countries have that in the world, and 69% of countries in the world have that, and in our region in red, it's 68%, okay? So we're about on par with the rest of the world. When you start looking at some of the other unhelpful laws and policies, I'm just going to say this again, very frankly, we are the epicenter of really bad law and very bad policy. So let's look at, for example, our region, and this is an issue here in Khalij as well. Around the world, 22% of countries restrict people living with HIV, whether they can come into your country or they can come and stay in your country. In our region, that's 74% of countries. And if we go ahead to, for example, the far right, so in every category of bad laws, we're at the top of it, okay? We have lots and lots of them. But let's talk about good laws. Laws, for example, that protect people living with HIV against stigma and discrimination. Around the world, 45% of countries have this sort of legislation, but in our region, only 16% of countries. So our legal frameworks are not helping in the region, and they are fueling the HIV epidemic. Some of the other factors that are driving the epidemic are low political priority. It is absolutely wonderful, and we congratulate Bahrain, really from our hearts, that the Ministry of Health is taking HIV seriously. We appreciate it. We need your help in convincing other countries in our region to do the same. Because when politicians say, oh, we have a million other problems, we don't have time to deal with HIV, by the time HIV is so visible that they do see it as a problem, it is too late. And so we need countries with foresight to help convince the others that we need to act as a region now. When HIV is not considered to be a political priority, it doesn't get enough money. It's as simple as that. And let me show you what that looks like in our region. So this is the amount of money that's available, been spent on HIV response in the Middle East and North Africa. Okay, so on the far right, by 2025, UNAIDS estimates that we need to be spending about $1.2 billion a year in our region in order to get our HIV response on track to end HIV by 2030. Okay, so that's the bar on the right. The bars, those tiny bars that you're seeing, is the money that we've been spending in our region since mid-2000s. Okay, so it's only about $200 million. It's like a sixth of the money we need to be spending. And what's interesting is that most of this money is coming from the Global Fund in terms of financing the response in many of our countries. Now, you may have heard today that the Global Fund is going through a replenishment. The target is $18 billion, and they've been able to raise $14 billion, which is welcome, but it's not enough for our region. And so we are in trouble financially in terms of finding enough resources to adequately respond to HIV. Oh, and by the way, globally, the estimate is that the world is going to be needing to spend $29 billion by 2025 to get the HIV response on track. At the moment, we're spending around $22 billion. Okay. Some of the other factors that are driving the epidemic in our region, and Nasreen just spoke a little bit about this as well, and you heard from Bruce. Bruce, the Prevention Access Coalition, this is the importance of civil society. In our region, when governments do not want to engage on HIV, again, because they have COVID-19 and other priorities, it's very, very important that civil society, non-governmental organizations, patient-led groups have the space to work. They are your partners as practitioners, and we will only be able to truly tackle HIV in Bahrain and across our region if they are fully engaged and they have the space to do so. And there are lots of other factors that are driving the epidemic, including, Nasreen talked a little bit about this, what I call cultural reticence, the reluctance to really speak about some of these difficult topics related to sexuality freely and frankly. But until we can do that, we will not be able to win the battle, to really, really tackle HIV. So very quickly, there have been a lot of international agreements on HIV. We have a new global AIDS strategy, and Jumana, I think, spoke to some of this morning. Bruce mentioned the political declaration on HIV/AIDS. This was a big landmark international agreement that was signed at the United Nations last year. Bahrain is one of the signatories, thank you very much. And this commits countries to a wide range of measures to ending HIV by 2030. The global strategy, I'm sure Jumana covered some of this, but essentially we're looking at, there's clearly a clinical medical part, there's a lot of elements about human rights and laws and policies, and then of course there is the element of healthcare financing. How well is your healthcare system structured? Can it adequately respond to HIV? So suffice it to say, it is a multi-sectoral response, very complex network of factors and actions and actors that have to come together to really grapple with HIV. The targets, and we have a lot of them. I'm just going to finish with this. Essentially, what needs to happen? Bahrain, you have this marvelous opportunity, really, to forge a 21st century HIV response. But for that to happen, you are going to really need to come up the curve, as we've heard, and we're here to help you. We want to work with you hand in hand on bringing the innovations in prevention, testing, and treatment and making sure they reach everyone at risk. Information for transformation. You really do need, and we'd love to work with you on this, better epidemiology of what is really happening in your epidemic in Bahrain. We do this through things that are called integrated biobehavioral surveys, population size estimates, modes of transmission studies. Again, this is the information that will help you understand what is the real state of your epidemic in Bahrain today and how to best deploy, with laser-like precision, your resources to really ending HIV. And part of all this response, as we've heard before, is getting people who are living with HIV, people who are vulnerable to HIV, truly engaged in this response, and dealing with a number of the more challenging societal issues. Again, we're here to help you on that and to take it at a pace that is comfortable for you, that is relevant to your cultural context. These steps will only work if they stick, right? And we don't want to go too fast. It's wahda wahda. We're going to take our time, but we want it to be steady progress so we get to the target we all want to reach. And I'll just give you this. It's very important to remember the human face of HIV. And I'm just going to read you this because we get messages every day. I personally get messages every week from people living with HIV from across our region. And if you just give me 1 minute just to read this out, because I think it's important for you to understand what living with HIV really looks like. This came to me last year. Dear Dr. Shireen, I'm a 29-year-old Syrian living in Erbil, and I'm registered as an asylum seeker in Iraq. When I was renewing my residency, I tested HIV positive, and based on the rule here, they are going to deport me to my country of origin, which I already ran away from because of the bad situation there. I'm so despaired, and I don't know how to act. I am here with my family, and no one knows about my infection, and I want to keep it that way. Please, can you help me? So my colleagues and I at UNAIDS and working with our co-sponsors at WHO and UNHCR and others worked to try to find a solution for this young man. And about 6 months later, he sent us this message. Dear Dr. Shireen, after receiving your previous email, the next day your colleague contacted me and he gave me all the information I needed based on his experience. 2 days ago, I got a call from the UNHCR they have applied to the Ministry of the Interior to stop the deportation, and the response was positive. So now they are negotiating for me about the possibilities of residency. Also yesterday, they informed me that they sent my medical case to the Department of Preventive Health, and I can go there to get medication. I really can't find words to thank you enough. What you have done for me was very important, and I really do appreciate it. It's not rocket science, what we're doing. We have the tools to be able to help people living with HIV, to prevent HIV, to help people who have HIV lead full and successful lives. We just need to have the will and the determination to apply it. So finally, I would just like to say that HIV, you know the concept of the neglected tropical disease. HIV/AIDS in our region is a neglected disease. It affects hundreds of thousands of people are infected. It affects millions more. It doesn't get enough political attention, and it doesn't get enough money. We can change that. But we really do need the help of countries like yours and others who have the political commitment, but frankly also the resources. So we want to help you build your response, and then we need you to help us in the rest of the Middle East and North Africa. So the time to act is now, not tomorrow. And with that, I want to thank you for your attention. And I'm here for the duration of the conference and would be love to be able to talk to you more about this and answer your questions. Many thanks.
Thank you very much, Dr. Fakhi, for an excellent review of the challenges that we are facing in our region. I'm sure there are many questions, but for the sake of time, we will defer it during the break times, and maybe we can also sit all together in the panel discussion. It gives me my great pleasure to introduce the last session. And the last session it is a Gilead session. The chairperson is Dr. Batul Sulaiman. She's an HIV specialist from the Kingdom of Saudi Arabia. Dr. Batul.
Thank you. So, creating possible in HIV care for a better today and tomorrow. This is the title of this session. And for more than 30 years, Gilead have been producing a lot of medication that improve the life of people living with HIV. The mission to discover, develop, and deliver therapeutics for those people, and it's an honor to introduce the speaker, Dr. Jamila As-Salman. She's well-known and a pioneer in infectious disease. She has an American board in internal medicine, geriatric, and infectious disease. She's the chief of medical staff of also the National Antibiotic Committee and the Geriatric Service in the government hospitals of the Kingdom of Bahrain. Dr. Jamila, the floor is yours.
Thank you so much, Dr. Batul. Thank you. Thank you all for being here. Thank you, Gilead. I think you are one of major sponsors for this activity. So this part will have two presentations. I'll start with the first part. The main objective of this presentation is the important concept in the field of HIV, which is linkage of care, and how we can get the patient to start the treatment, continue being with us, and have the improvement. So when we look for the pathway of the patient, once they get diagnosed, till the ultimate goal of viral suppression, what we see is they should be diagnosed, and you hear throughout the date from the previous speaker is how much we have really delayed and limited diagnostic within our region. Then linkage of care, because otherwise you can't start medication. You cannot increase the rate of medication and retaining care and achieve the viral suppression if you don't start with the first part, which is testing. This is very important, and how we get people. You know, the targets, we talk about them today, 90%, and then we move 95%, and we're looking for the quality of care, but it needs a lot of prevention methodology, getting people to be tested and linking them later to the care we are looking for. You heard about a lot of strategies, a lot of things that, we had, the strategy, and we were looking for in 2022, what are the numbers of HIV we are looking to see, and 2025, what we want to see. But what's amazing, if we do what we have to do, the prediction model is that we probably will be able to decrease. So at the end, you will see what we are looking for, okay? So if all the strategies we are thinking about, and you saw, probably within the previous presentation and even earlier today, a lot of strategies with WHO, with UNAIDS, national strategies for HIV, they have to work. But the problem, they don't work as we wanted. Because of what? So the milestone, the steps that has to be taken by each of us, by each country, are not done properly. There are a lot of things that we can do, and that's why we didn't reach the numbers. And Dr. Shireen just mentioned how we are in the area, we didn't do well. Even if you have budget or no budget, you have problems, you have war zone or no war zone, there are a lot of problems that limited us from really working and providing all of this to our patient. I'm not going to talk about what's happening in the region. I think you hear that, but the most important thing is that despite low prevalence, that's when a lot of people say, why we are talking about HIV? It's less than 0.1%. Who cares? No, we care because it's a problem. Because if you look at the HIV related in our region, it's been increasing. Despite we have good decrease, but it's not as the other country, which means our treatment is not perfect. Our patients are not suppressed. They are not getting the care we want. We are missing it, missing a lot of opportunity within the 90s from being tested, being on treatment, being suppressed. So all stages are impacted. So it's not the best way. And I put this slide because the COVID-19 really highlighted that within 2 years, we are in the third year, with everything happening from, people being, locked down or no lockdown, there was an impact. So people, if they don't have access, this is the best example when you're talking about linkage care. So if they don't have a good access, what you will see is that testing number in the region decreased, okay? And the other part of the story is that the impact on, the number of cases discovered. This is not because we have decreased number, but we were not testing people. And probably it's being seen, we have a trend now that we saw people after 2 to 3 years now of the pandemic coming as a late diagnosis, coming very late, and that's not good. And really it's not good. Despite most of our country in the region, we were maintaining the essential services. So the number speaks for themselves. We are the worst Middle East region, the whole thing, despite there are good countries, and we'll see example from the region that we did well. And if you see here, this is the Middle East country, and this is the patient who knows their status. So it really goes back, all of it, to the testing. If they know their HIV, probably in our GCC country, it's easy. We'll start, we have the best treatment, they will be controlled, end of story. But it's not like this. How we can get people to be tested more in the region. Issues and challenges in our region are, very well highlighted in the previous. I'm not going to talk about them because of it affects certain groups, which nobody wants to talk about them. Men having sex with men, female sex worker, IV drug user, prisoner. So that's because it's in certain group, the high risk group, and that's we are not looking at the problem, which does not mean it's not existing. The other thing is that most of probably ministries or public health authority, they have more important things to talk about. Have COVID-19, monkeypox, I don't know, it comes back and there are, cardiovascular disease, people are dying of cancer. Why we should talk about HIV? Why we should even have a budget to address HIV, but it's important. And the other part, we don't know, as Dr. Shireen mentioned, what's the size, the actual size of the problem, because we don't have good data in the region. We don't. Go and do literature search, you'll see really, even the field of ID, we don't do much research in HIV. Really, we do about antibiotic resistant, I don't know what, but in HIV, it's very limited. So we don't know. We don't know the epidemiology, we don't know the behavior behind it and how to tackle it. And that's why important to highlight these issues. I use this STAR, because thanks to Gilead, they have the STAR program. Actually, the STAR program is an educational program by Gilead, and it's meant to educate non-ID. I think we spent, as an infectious disease specialist, talking about HIV among ourselves, that the rest of the world, they don't know what's happening in the field of HIV. So I consider about certain concept. This is very important to know about. is testing, screening. Why, who, and when. Why we are testing people? The number one is the only way to know if you have HIV or not. There is no other way. And you hear Dr. Nisreen mention that people are coming, they are afraid because they know they've probably been exposed. And these are the people that you have to pick up, because if they are positive early enough, you can really start the treatment, okay? If they are negative, this is the chance you pick them up to give them education for prevention. These are the best people. So this is where you want to start your linkage of care pathway. So knowing the status can help keep you and others safe. So caring about the partner, this is the only one way, is that you get tested. Who should be tested? CDC recommendation was very clear that, everyone from 13 up to 64 years of age should be tested at least one. Everyone, And this is, the story we were just discussing this morning. If you test somebody, we don't take consent here. We do testing. We don't, because it's part of baseline investigation for fever, for different syndromes. We don't take consent, because once you said you will test for HIV, they get intimidated. You think I have a problem? You think I will have HIV? It's not like this. I think the idea should be tested, because universal testing, because this is the only way you will know what you have, otherwise not. But saying that, it's very important to look for the high-risk group. The high-risk group, it's there. Who are these? Who are the high-risk group? Okay, so whom you will really test. Strongly recommended if we have what we know for years, AIDS-defining illnesses. So people are coming with Kaposi sarcoma, okay, TB. This has to be tested for HIV. That's the guidelines. And still, one of the indicators that we follow, even with WHO and reporting, how many patients with TB tested for HIV? How many patients with HIV were tested for TB? You have to do them. And this is where we monitor all the countries. So it's defining condition. And then if the prevalence is high, you probably go with some of the high also risk diseases. So if patient present with malignant lymphoma, Hep B and C, you are doubting it, you will ask for HIV. Other STDs, you will, and probably, the story of monkeypox brought to us the concept of STD. And you saw the cases reported that the patient has HIV, and I think Hep C, I don't know, COVID with monkey, I don't know, something like this, but that's it. This is normal. This is population will have, so they can be diagnosed. They pick the patient with HIV, at the same time they have monkeypox and probably COVID. And then if you still have the prevalence, okay, they have serious implications. Some of the diseases that you have to address it, systemic candidiasis. Yeah, I'll test for HIV, because they should be immunocompromised to have systemic candidal infection, and these are the people who should be tested. This is very important. We test them, yes. What kind of test we have for HIV? I'll not go in the details of testing, but you have exposure, patient get exposure. 7 days, within 7 days, actually, it's 1 to 2 weeks, you can do a viral load and you can pick it up, okay? You can pick it up that early after the exposure, because it's, replication millions of units. And then there's the P24 antigen, it's not done anymore, it's, just probably research lab. And then the serology, which, we ask the patient for the, HIV testing. This is what's been done, confirmed usually by public health, and then we call the patient. So usually in average for HIV test, not the viral loads to be positive, where the antibodies are there, it takes 28 days, 28 days. So there is already, when your patient diagnosis is being 28 days. That's if you pick them up. But most of the patients that we see, they've been infected for years, living normal, living their life. They never attended any medical facility because they didn't have any problem. Because when they start to show problem, then they search for medical facility. This is the message of testing. First, if the patient is positive, you will get them and link them to the care, start treatment. That's done, okay? And you will start treatment, and what, Dr. Bruce just mentioned, you equal you. So you start treatment and protect the partner. Then you will move. If they are negative, get them there. You can give them PrEP, as Dr. Nisreen mentioned. You give them education and how to protect themselves from getting infected. But what are the barriers? It's easy, get them tested. Why we are not testing enough? What we understand. First of all, stigma. Nobody wants, and I really guarantee, no one come to you and say, test me for HIV. Even if they come with certain complaint. Within the talk, they're probably, yes, you can test me for HIV, and then you sense it in their voice. But it's usually not. It's usually. So stigma is a major, major problem we have. Discriminatory law and policies, Dr. Shireen mentioned it, because there is a culture, there are laws, we have law in Bahrain, we are really blessed to have it, that, against discrimination, but there is culture. Even if you have a law and people are not implementing, you will be in trouble. So the culture has to change. Social determinant of health and the access of health care. This is very important, especially I think we experience it within the COVID-19. Late diagnosis is a problem, and we've been, even our practice in Salmania Medical Complex for years, with the advances of ART, antiretroviral medication, we didn't see, probably more than 7 to 10 years, no late diagnosis. And now after the 2 years of pandemic, despite we didn't close, people were limiting their movement, so they are presenting late, really late. And this is, you lose the patient because your medication does not work really very well in this stage. So the poor outcome, this is what we don't want it to happen. We want early diagnosis to give the best treatment for the patient. So what intervention I have? I want to do testing in my country, what option I can do? Probably, opt-out testing, it's there, you can be tested, universal testing for everybody, index case finding, and sometimes it's easy, sometimes hard. Believe me, even if the people married, even breaking the news to their partner, it's a long story. Believe me, it sometimes takes years before they are even allow us to talk or do something. And they say, okay, I live alone, she's alone, but it's really hard. They know that they will destroy their marriage if they even mention it. So it's not easy. Expansion of home self-testing, I think this is a good idea. Strategic use of text messaging, social media, people encourage each other. Geographic hotspot and offer it. Financial incentive for some people, strategies, combating stigma, and this is really a very important thing. What are the recommendations? WHO really put a lot of recommendations to improve it. One of them is antenatal, rapid testing, do it for syphilis at the same time for HIV, and really we did very well in Bahrain for antenatal. We don't have transmission from maternal to fetal, which is good. We don't want to see it. And some at-risk female has to have a repeated test. The other thing that can be done, as we mentioned, is the social networking, because people encourage, okay, I tested, why you don't get tested? I think this is probably how we can encourage them to do it. Self-testing is very important. I think this is the time to introduce it in our country and people be able to test it over the counter, rapid test, see there, and if it's positive, they can come. That's probably the easiest with less stigma to do it. I think the GCC, I don't know, Qatar, you started, some of the country, yeah, Qatar started, over the counter, which is good. So it's acceptable, it's accurate, safe, improve access to HIV diagnosis and care, and you can have focused intervention. As a healthcare worker, all of you here, that's important. We want you to pick up these cases because they will not come to us unless it's where you are, you probably see a patient, and we mention who should be tested. You are seeing a lot of people, so you should know. High-risk group, we know probably them. Indicator, condition, the list that we mentioned. Suspected, just test with it, order it. If they are an outpatient, emergency room, order for HIV, you will pick up cases, and I think this is good. The other thing, okay. The other thing that's important, we said we'll have to test, and they are positive. The next step, which is very important, is how soon you start the treatment. To keep them in care, remember the title of the lecture is linkage to care. You test them, they are positive, you start as soon as possible. And that's very important because once the patient is diagnosed with HIV, okay, then they get confirmatory test usually, and then they initiate the first visit. This is the usual how we were doing it. We see them, we ask for basic lab, we order another appointment in 4 to 6 weeks, come back, we'll discuss the treatment. Now the rapid initiation, and we'll have a lecture discussing all these options. Start at the same time, don't wait for the rest because of good reason. And these good reasons are regarding to the recommendation, we'll go to the reason. The most of the medication you can use them because, but now we have a better option. Integrase inhibitor medication are on the top of the list for the treatment, and these are really good to start. WHO has the same recommendation. So what happened? This slide, usually we teach it to the medical student, and that's where rapid initiation is very important. So from HIV to AIDS, okay? The first infection here, when they get exposed and they have the acute HIV infection, you know that acute HIV infection is non-specific, viral illness, fever, I don't know, it can be hepatitis, meningitis, it can be anything, ulcers, you can pick them up. So once they get diagnosed here and you miss them, you don't do testing, they will progress. The problem is this period where HIV viral load increased, their immune system is less, low CD4 count, and they are living normal. It can expand to 10, 20 years. And at this time, they are infecting their partner. They don't have anything. They will come to you later, and this is what we saw recently at this stage when they have AIDS. They come, and we saw them. And even within COVID-19, we saw people having COVID, but they were admitted not because of COVID. They were sick because they were in the stage AIDS. Okay, so that's where we put several cases like this. The studies, the evidence, will not go into details, showed rapid initiation of the antiretroviral increase the retention in care and viral suppression, and decrease the likelihood of loss of follow-up and death, and that's the aim. So it's not only testing, we know how to do testing now, we should initiate it, we should plan it in our countries, and now how to start the rapid treatment. What is that? U equal U. I think this is something that probably you can go out from this conference with. If the patient is undetectable, and we have to be very clear to the message, you don't need, undetectable, no, you are in treatment, but you can use condom with it. That's extra prevention. Undetectable is untransmissible. So that's where we have to make it transmittable. That's where we have it to be clear for our patients. So we went from testing to rapid, and I think it's not moving. Can you move the slides back? Oh, I had conclusion. So what's in the field of HIV that probably make it better? So far, we have really great medication, but we are looking for better actually all the time. We are talking for fewer drugs, long-acting injectable medication that may increase the compliance of patient because they get injection every 3 months instead of 1 pill a day. Probably it's good for some patients, not all patients, but probably it will be good for some patients. Again, these numbers are very important. For patient to receive ART, antiretroviral, get linkage to care, still internationally, it's not the best. Really few countries probably they can report up to 90%, but most of the world not, and we are doing worse in our countries. So the barriers are very clear to us. I think we have to tackle them. If you have structural barrier where the patient can get access, race or ethnicity, linkage to care, a lot of issue about the HIV patient has to be solved, and then probably you can move forward. So that's the scheme, from screening to diagnosis to linkage of care, looking for the optimal care. And I'll go for the last, probably, this is very important to emphasize the term linkage of care. What we passed through the COVID-19, this is kind of prediction model. If there is disturbance in the services we are giving our patient, if it is 3 months disruption of the service, the number of deaths, will be around 70,000 increase. If 6 months, it will be 80,000. If you have 2-year disruption of your service, you will see a 150,000 new deaths. So that's where getting them earlier, test them, start, makes sense. So COVID-19 gives us another evidence how soon they should be tested and how soon they should be started on treatment. All of us are involved. It's really integration of several primary prevention and primary care, sexual and reproductive history, testing and treatment, and vertical transmission for our patients. And that's the cascade from testing, monitoring, starting treatment, and counseling till the advanced viral care. And I think with the take-home messages, we really know now what's happening, where the patient, where the HIV infection in our society, it's not everybody, but they are the people who probably cannot get to the service. And with the law, probably if they have to leave the country or lose their work, make it less likely for them to come and ask to be tested. So it's very important to keep it for mind. Many possible intervention to improve testing, and I think we have the ideas. I think this is the time to improve it, to increase the number of cases we are seeing as in new cases as early as possible, and then link them to care and start the treatment. So you have to modify the structure in your institution and how patient can be referred to you to start treatment. And I think that's all doable if you put our efforts together from education, awareness, testing, and start early treatment. Thank you.
Thank you. Thank you, Dr. Jamila, for the perfect timing also. The next speaker will be Dr. Ali Al-Umran. He is a senior consultant of infectious disease at Hamad Medical Corporation, clinical professor in infectious disease in Qatar University at Doha. And he finished his fellowship at the Royal College of Physicians in London. And he was previously the head of infectious disease department at King Faisal Specialist Hospital and Research Center. Dr. Ali, please.
Thank you very much, Batul, and thank you, Dr. Jamila and colleagues, for inviting me. This is part of the Gilead Symposium, so this is obviously a Gilead-sponsored session, and there are important disclosures for you to consider while I deliver my talk. The content is mine, and they reflect my understanding of the evidence, some of which I will share with you. And the title, as you all know, is about confidence and peace of mind in association with antiretrovirals, and for the purpose of this talk, it's focused on Biktarvy, that's co-formulated bictegravir with FTAF. We all know that HIV treatment is much better. We know that our patients are much more likely to survive now than they had done so 10 or 20 years ago. But being alive is not the same as being alive and happy. It's not being alive and actually being satisfied with the quality of life that you're living. And in the past 10 years or so, this has become increasingly more recognized that individuals who live with HIV are not they don't enjoy the same quality of life as those who do not have HIV, despite the fact that they have on the face of it what is seen as successful treatment, i.e. Suppressed HIV viral load and relative immune reconstitution. And that meant that whether we call treatment successful or not is no longer hinges just on being suppressed and having a reasonable or an acceptable CD4 count. It's also about how good you are in terms of quality of life. And when you look at indicators of quality, these need to become part of our treatment paradigms. And what I will do in the next many slides is to demonstrate to you that Biktarvy, co-formulated bictegravir with FTAF, is able to provide the majority of patients with most of these areas related to effectiveness of treatment. But for context, it's also important to recognize that current treatments are extremely good. And it's a competition between highly effective and highly safe agents. And the gap between different regimens and different treatments is not as wide as it used to be. And that is why when you look at different treatment guidelines, you find that they recommend, as first-line treatments, multiple choices. And that's obviously great for our patients, and it certainly makes our life a little easier. In terms of efficacy in relation to Biktarvy, we have data from multiple randomized clinical trials, both in patients who are naive to treatment and also those who have treatment experience. And collectively, they demonstrate high virological efficacy and ability to re-establish CD4 counts without too much concern in relation to safety, in particular with things that we had concerns about in the past, renal dysfunction, bone dysfunction, and so forth. In the registrational randomized trials of Biktarvy in patients who were naive to treatment, there were two major landmark trials. And what I would like you to note about these randomized trials is that the comparator was always a first-line agent. So in 1489, for example, the comparator was a single tablet regimen of abacavir with lamivudine and dolutegravir. So this is a first-line agent, one that still is considered among us the first agents to use in patients newly treated with HIV. The second study compared again against dolutegravir with another backbone that is considered first line. So the comparators here are high, top-level comparators. They're not second-line agents. And the primary endpoint says it is the case in registrational studies would be virological suppression, according to the FDA snapshot. In both of these clinical trials, there was a double-blinded phase, and it was followed by an open-label extension where all individuals knew what they were taking and all physicians knew what they were taking too. What is new and relatively novel about the data that we have now in relation to the two studies is that the extension has been, the follow-up extension has gone as far as 5 years. You would not be able to find any randomized trial of treatments in HIV with follow-up up to 5 years in a randomized setting, and this is really exceptional. The baseline characteristics of patients who were included in these trials is also relatively common, except the underlying or the background racial mix in these studies was far better than many others. Less than 50% of individuals who were enrolled were white Caucasians. There was high representation of other ethnic groups. And that is, again, something that needs to be noted because many antiretroviral clinical trials, representation from non-white groups tends to be very limited. And this is one short look at what happened with these patients over an extension, as I said, of 5 years. The top line represents patients who were still on treatment and for whom we have virological data towards the end. And you can see that nearly all patients who we had data for were still undetected for 5 years. Now, the piece of news here is not just the fact that they were undetected. What you need to take a step back and recognize is that this is truly durable. To achieve undetectable viral load within the first year is obviously something very important, but to maintain it for as long as 5 years and to have randomized data to demonstrate that is really remarkable, and I think it needs to be acknowledged. We also have randomized trials in the setting of switch, and the bar in switch studies is always higher because by definition, these would be individuals who have undetected viral load, and to contemplate switching someone with undetected viral load is obviously a significant undertaking. Again, the comparators in these studies were among us first-line agents or treatments that continue to be recommended to today. So if you look at 1878, for example, the comparator was a boosted BI, but it wasn't an old-fashioned BI like Kaletra. The comparators were boosted darunavir and boosted atazanavir. And in the second study, again, the switch was from Triumeq. So again, a first line or a highly recommended agent. And you wouldn't be surprised when I show you the data that shows, again, sustained virological suppression going on all the way for 3 years. So whether you're starting Biktarvy or you're switching a patient for a clinical reason to Biktarvy, in those settings, clinicians and patients can have high confidence and peace of mind that it's not likely that they will lose or not achieve that very well-treasured viral suppression. Bictegravir also has a high genetic barrier to resistance. And again, in the same clinical trial where it was compared with another agent with high genetic barrier to resistance, dolutegravir, it is again incredibly remarkable. People like myself who have been doing HIV for more than 20 years would know this, that this is really an unusual thing. To continue individuals on the same regimen for more than 3 years and not see a single case of virological resistance is a testament to how highly durable these regimens are and how the risk of developing resistance is extremely low. And across the randomized trials that I showed you in the earlier slides for Biktarvy, there wasn't a single patient who had documented resistance, although a handful of patients did reach a threshold that allowed viral genetic testing, i.e. they had viral loads of more than 200, but none of them had documented genotypic resistance to any of the agents in these regimens or anything else. Now, this high genetic barrier to resistance, this long durability, is backed up also by in vitro work. We know that forgiveness, which is a feature that allows you, the patient, to miss the occasional dose, and this is a term that was coined about a decade or so ago. So a forgiving regimen is one that allows you to act like a human being. And human beings obviously sometimes are late to take their medication and sometimes they forget to take their medications altogether. And if you're taking a forgiving regimen, then your regimen will allow you to do that with relative safety. You wouldn't necessarily lose control just because you acted like a human being. And if you were to develop an in vitro model to understand the effectiveness of an agent or its forgiveness, then this is one way to do it, where you would model what would happen to your serum levels if you missed 1 dose or 2 doses or 3 doses. and whether these doses were consecutive, so you missed 1, 2, 3, 4 days, or whether it was intermittent, like most patients would do. So you would see the first on your left and the second on your right, depending on how frequent an individual might be missing. These are not real data, these are modeling in vitro data. And what you see in the case of Biktarvy, if you were to model what would happen in a human being who misses one, and then a second, and then a third dose, these consecutive missings of doses do not result in emergence of resistance until you've missed so many, until you've missed 3 or more. If you were doing what most people would do in real life, which is that they would take their medication, but take them late or miss them, then resistance does not emerge in vitro when you're using Biktarvy. So as I said, these are in vitro data that explain what we've seen in clinical trials in association with Biktarvy. We also know that the higher, the more your patient is adherent to their regimens, the more likely that they will achieve and maintain and sustain virological suppression. Now, you might all want your patients to be 100% adherent, but in real life, this is rare. Most patients would be doing well if they adhered 80% of the times. They would be doing fantastically well if they've achieved 90 or 95%. So again, in these real-world data, what you're looking at on your left is, on the left side, is what proportion of individuals achieved a target of 80%. And you could see that this was more likely to happen if they were taking single tablet Biktarvy compared with the other two agents there. And if you were looking at 90%, again, only 50% of patients would achieve that, but it's more likely with Biktarvy. But more interestingly, is what happens in terms of the association of achieving those levels of adherence and your likelihood of achieving a sustained virological response. And what you're seeing on your right-hand side there is a logistic regression that shows that even those who were still not achieving the kind of adherence you want with Biktarvy, this was not associated with an increased likelihood of failure, whereas that was the case there. So real-world data support the forgiveness, the durability that I was talking about. And again, despite your best efforts and despite your patient's best efforts, some patients will have detectable viral load every now and again, what we call viral blips. And if your patients are experiencing lots of viral blips, then that can compromise their regimens and can lead to virological failure, particularly if those blips were higher than 200. And again, there are very good data from Biktarvy that show that this is actually not the case. So if you had a patient on Biktarvy and they were experiencing blips, then those are less likely to result in virological failure compared with other agents. Again, data that demonstrates the same. It's about confidence in the regimen and peace of mind and less worry about these regimens failing because of virological inefficacy. Beyond viral efficacy, it's obviously important to talk about safety. And when you have such long clinical trials and very large numbers of patients involved in these clinical trials and have very, very low rates of adverse events, minimal discontinuations, sometimes in some clinical trials less than 1%, then obviously these regimens are highly well tolerated. One concern that emerged in the last 10 years or so since the introduction of integrase inhibitors is weight gain. And obviously weight gain is in a large part physiological return to health, and that's why we see it mostly in the first year after starting treatment. And beyond that, there are important biological considerations, including the effect of the treatment. So you could see here the weight changes with Biktarvy studies mostly in the first year. In a different study that looked at 3 different regimens in South Africa, dolutegravir-based regimens compared with efavirenz-based regimen, there was concern that weight gain seemed to be excessive in the integrase inhibitor arm and also in the TAF arm. But it wasn't very difficult to explain this biologically. First, most individuals who gained weight were obviously Black Africans. The study was in South Africa, and there's a genetic predisposition to weight gain among that race. Also, this was seen more frequently in women, and there are also underlying genomic variations that can push weight gain. But more importantly is what is known as the weight suppression effect of TDF, tenofovir disobrixyl fumarate. If you take TDF, even if you don't have HIV, you gain less weight than someone who has HIV. And why do I say this? I'm showing you 2 clinical trials. These are PrEP studies. These are studies in individuals who are HIV negative. These are individuals who are taking medication to prevent infection. And on your left-hand side, you see the IPREX. And in IBREX, TDF, TAF, Truvada, was compared with placebo. And individuals who received placebo gained more weight than those who received TDF. And if you look on your right-hand side now at the Discover study where TAF compared with TDF, you see the same effect. In other words, those who take TDF gain less weight. It's not necessarily those who take another regimen. It's important to understand the two because you will want to counsel your patients about potential adverse events. Simplicity is another feature of any single tablet regimen, and that obviously is a feature of Biktarvy too. And in addition to being a single tablet regimen, it's also an extremely small tablet. All of them are small, but smaller sometimes makes some patients happier and more likely to take their medication and adhere and achieve the kind of suppressions that they want. Also very important to note that patient experience, that quality of life that I talked about right at the beginning, was consistently better amongst individuals who were receiving Biktarvy compared with whatever was the comparator in the clinical trials when questionnaires related to quality of life were included. So it suppresses the virus, it results in immunological reconstitution, the effect is durable, and patients experience better quality of life because they're less fatigued, they have better sleep, they have better appetite, and so forth. It's also an agent that is suitable for rapid initiation, something that Dr. Jamila touched on, because it's got this high genetic barrier to resistance, because it doesn't require pre-testing for things like hepatitis B or genotypes. And it is amongst the agents that are recommended by current guidelines for rapid initiations. So if you look at Biktarvy overall, and I quickly went through the data because I knew that you needed to be at lunch at 1 o'clock, and you should all applaud me really very well because I'm going to get you to lunch at 1 o'clock. But what I want you to know as you have that lunch is Biktarvy is a good agent. There are other agents too. The difference between different treatment regimens now has become very narrow. What Biktarvy can do in addition to what others can do is it can give you a lot of confidence that your patients will suppress and will remain suppressed for a very long time. It's highly well tolerated and it's suitable for rapid initiation. Thank you.
Thanks a lot for the two speakers for the outstanding presentation. We'll hold the mic to lunch break. Okay, any questions?
Okay.
Okay, so we'll go to lunch break. We'll be back by 2 o'clock, please. Thank you.
Good afternoon. Assalamu alaikum wa rahmatullahi wa barakatuh. I think we need to start the session, afternoon session. So my name is Dr. Muna Al-Muslimani. I'm Medical Director of Communicable Disease Center at Hamad Medical Corporation, State of Qatar. So I'm delighted to announce Dr. Ali Umrani give a speech about updated guidelines in adults. As you know, Dr. Umrani, he's a senior consultant in adult infectious disease at Hamad Medical Corporation, and he's interested in immunocompromised patients. So Ali, please.
Thank you very much, Kuramana. It's my pleasure to be up here again. So I'm talking now about treatment guidelines, HIV treatment guidelines in adults. Unlike many other medical conditions, HIV therapy evolves rather quickly in many aspects, and most HIV guidelines are updated at least once a year. Some guidelines are updated less frequently, but most get updated once a year, sometimes even twice or three times a year, depending on whether there's anything newsworthy. And among us, the most influential international guidelines, I picked those three: the IIS, the International AIDS Society from the United States, and also the DHHS guidelines from the United States. And it's interesting that there are some differences between them. And I also picked the European guidelines in their latest version. And as we said just before lunch, because treatment is about getting it better and it's getting better all the time, there are small differences sometimes in how different guideline committees see priorities and see certain regimens and different contexts. And based on that, they make slightly different recommendations. We're in a very fortunate position because we can choose whatever we think fits most our own clinical setting. So if you look at this table and ask yourself, within current versions of those guidelines, what treatments are considered among us the first line options for individuals starting their first ever regimen? And all three guidelines that we picked consider Biktarvy or Bictegravir with FTAF as a suitable agent. When we say that, it doesn't mean it's the only agent, but it is an agent that is suitable to start most patients who are about to start their first regimen. There are other treatment options also that are suitable to be used first, and those are dolutegravir based. And it could be dolutegravir co-formulation, so that would be a single tablet, or it could be dolutegravir plus a second pill. Now, if you compare those three, again, it's about how refined the committee want to make their recommendations. So if you look at IIS, for example, they see that dolutegravir co-formulation with abacavir, in their opinion, not a favored first line, mostly because of abacavir-associated toxicities and hypersensitivity and the need for testing before you start. It doesn't mean it's not an agent because that you would use as first line, because other, obviously, guidelines would recommend it to be the case. So the way I see this is that if you were in a setting where getting hypersensitivity testing HLA-B 5701 is not a problem, and you have experience with abacavir and you can recognize hypersensitivity and you can counsel patients competently, then there's no reason you would avoid that. But IIS would feel it's not necessarily a first line. Again, on the far right, the Europeans being Europeans, like more choices and like more options and like to simplify things. So they'd say, well, dolutegravir is still an option, even if you combine it with a second pill, being abacavir 3TC. Small changes, nothing really very big. They also all think that dolutegravir with a second pill, that any formulation of tenofovir or FTC 3TC is a first-line agent. And raltegravir, as far as the Europeans and the HHS. Raltegravir doesn't get the same level of recommendation with IIS because it has twice daily mostly prescribing, unless you use a bigger pill once a day, and it also has a lower genetic barrier to resistance. So if you were in a setting where raltegravir is the only integrase available to you, then obviously it's a very good option and you should be using it. But if you were in a setting where everything is available and everything is accessible, then you may want to choose something else, perhaps a dolutegravir or bictegravir-based treatment. Again, you combine it with whatever you have, depending on your local considerations. It may be that cost is a driver. It may be that most of your patients don't mind taking 2 pills as long as they're once a day. These sorts of tables are interesting. They're very good. They make life very simple for us and for our patients. But at the same time, they show how far we've come as far as antiretroviral therapy is concerned. The Europeans also consider things like boosted protease inhibitors, but not necessarily as the first option that comes to mind when you're about to start treatment. 2-drug regimens obviously is something that has been around now. Several different 2-drug regimens have been tested, but the one that made it to the front line, i.e. being considered as an initial regimen, is that based on dolutegravir and lamivudine. And as you know, these come as separate pills, but they can also come as a combined pill, and that's a single tablet regimen, and that's good. But as you all know, 2 drugs as a start require that you rule out hepatitis B infection, and you need to make sure that the baseline viral load is not very high, and I'll come back to that. Now, if you're in front of a patient and you're looking at guidelines and you want to apply those guidelines to your current patients, you're going to have to tailor your selection to your patient's needs. And that selection is based on what you expect from the agents, but also what the patients expect and what are their specific needs, what comorbidities they have, what preferences in life do they have. And if you want to look at data that underpins those recommendations and you want to understand why bictegravir, dolutegravir, and 2-drug regimen, dolutegravir 3TC, are seen as above everyone else, all you could do is just look at an example like this study. After 3 years of comparison of single tablet regimen, bictegravir or dolutegravir, you can see very high rates of virological suppression. Again, just like we said before lunch, this is not just suppression, it's durable suppression in large randomized clinical trials. And obviously this makes them stand up, because if you go back to say 10 years ago, before integrase inhibitors, any new agent that is introduced, you will find that suppression rates rarely exceed 80%. It's only now that we started to get used to those figures of 90% after a year and 2 years. Before that, we never saw that. So integrase inhibitors generally are far more efficacious than other classes, and they're far better in terms of their tolerability. When you look at tolerability, looking at just one single slide tells you the whole story. Again, why these agents are preferred. If you were to treat hundreds of individuals, nearly 1,200 individuals for 3 years, and you only have one individual in each arm discontinuing because of adverse events, I don't think we will probably see anything as better as this in terms of tolerability. It's very difficult to ask for more than this. One individual out of 600 would stop because of a toxicity. Now, that's a number really that you have to think about very carefully. In most settings, people stop far more frequently for smaller things. When you look at the two-drug regimen, as I said, it is a regimen, it is useful, but there are one or two things that are important to point out. Now, when you look at the registrational study for 2 drugs versus 3 drugs, the first thing you will notice is that the comparator is not what you would consider today necessarily a gold standard, i.e. Truvada, because that's based on dolutegravir plus FTC TDF. So it's not TAF that most of us would prefer over TDF, mostly for toxicity reasons these days. The second thing you will note is that in the recruitment, in the eligibility, they obviously excluded hepatitis B infected individuals because that would be monotherapy. But they also excluded individuals with very high baseline viral loads, over 500,000. And when you look at the result and you stratify them by baseline CD4 count, you could see that patients who had lower CD4 counts at baseline didn't do so well. And that is why the guidelines do recommend that dolutegravir 3TC is an option, an initial option for most patients, but not those who don't have or have some of these features. So if you have a low CD4 count, high viral load, or co-infection with hepatitis B, then you shouldn't be using it. For someone like me, who's somewhat old-fashioned and started HIV the very old days of using so many pills and worrying all the time about resistance, if you were to tell me that I'm about to use 2 drugs and one of them is lamivudine to treat patients, the first thing that I would worry about is resistance. I'd say to you, no, that would be a very foolish idea because you're very likely to fail and you're going to fail with resistance. And obviously this is bad news. But I've been proven completely wrong because after 3 years of follow-up of 2 drugs in naive patients, only 1 patient developed documented genotypic resistance. So if you select your patients well, if you select patients who are less likely to have baseline transmitted resistance, even better if you have baseline resistance testing and it does not show M184 or other NRTI-associated mutations, then you'd expect a lot of patients to do well. The Gemini, or the 2 drug, the main driver for thinking I want to use 2 drugs rather than 3 drugs would be one of 2 things, either because you want to improve safety and tolerability or you want to reduce cost. Now, the combined bill is not necessarily cheaper than using 3 drugs. The second part, trying to reduce toxicity or improve tolerability, didn't really show very well in the randomized trials because, as you could see, when you look at toxicity, the rates of adverse events in 2 drugs and 3 drugs were not actually statistically significantly different. So you may want to do it, you may want to offer it to your patients might want to ask for it, but if you're doing this because you're trying to avoid adverse events, then that's not really based on data. And if you're doing it to minimize cost, then that depends on your local procurement costs, but generally it wouldn't work very well. And as we said before, and it's hammered into all of us, that when you take medication, if your patient takes their medication regularly, then their troughs and max are predictable and they generally maintain good viral suppression. But they start and stop, then obviously this would result in inhibitory concentrations of your antivirals, and this will allow selection of resistance. Now, to minimize this, one important factor is tolerability and adherence, and it certainly helps adherence if you can use a single tablet regimen. Now, if you're a purist and you want evidence, then the evidence is only that multiple pills are less good than a single pill. Multiple times a day is less good compared with single time once a day. But if you ask patients, if you were a patient and someone would ask you, do you want 2 pills or 1? Most of us will go for 1. So it's accepted generally that the fewer pills you have, the better. Although, as I said, the evidence really is not there that there's a real difference between 1 or 2 if your life depended on it. So a single tablet is good, and for some patients, the size of the pill matters too. And when you look at those first-line options, they all are available as single-tablet regimens, although as you could see from the guidelines, the summary at the beginning, they would allow also using 2 pills. Weight gain, we said, is a concern. But when you look very closely at the data, and this is a very good attempt where 7 different randomized trials were included in this meta-analysis by Paul Sachs and colleagues, and what they showed was 2 things. Weight gain, or the likelihood of your patient gaining weight on treatment, is largely dependent on things like how advanced was their baseline HIV. So if they have lower CD4 count at baseline, they're more likely to gain more weight. But that's not difficult to understand. You treat someone for tuberculosis and they gain weight. You treat anyone for any chronic condition, diabetes, and they gain weight. Return to health is associated with a weight gain, and that's understandable. There are also genetic factors, including things that are embedded in our chromosomes. It's embedded in our genes, but it's also things related to the treatments themselves. And it could be things like, are you using an integrase inhibitor? And all integrase inhibitors are associated with more weight gain than non-integrase inhibitors. But the data is strongest when you compare it with efavirenz. And efavirenz has a weight suppression effect just like TDF, and it also is associated with genetic polymorphism that makes certain individuals more likely to gain weight than others if they were using efavirenz. Also, TAF compared with TDF, but as I said before lunch, a lot of this is about TDF suppressing your weight gain. It's a similar effect to what you see with TDF in cholesterol. TDF suppresses your cholesterol. And some people go as far as saying, well, I would want to use TDF if I want to reduce weight, but I wouldn't go that far. I don't think this is the right strategy. Obviously, you need to consider comorbid conditions to make selections out of those options, and the obvious ones are chronic hepatitis B, but also things like renal impairment in those who are at risk of bone loss or bone disease, increased cardiovascular risk, and obviously underlying HLA B5701. These things could affect which regimen you use, and most of us would avoid certain things in most patients, but it depends on local preferences. Rapid initiation is a good thing. Among us, the first-line agents, only those two, dolutegravir-based or bictegravir triple therapy, are recommended as initial treatments. Outside those agents, also a boosted PI would be considered suitable for rapid initiation. This is when you start someone on treatment once you've counseled them and they're ready, and you've, to a large extent, excluded the likelihood that they have an undiagnosed opportunist infection. And if you were considering rapid initiation, then those two agents, as I said, plus boosted darunavir, could be options that you would consider. Apart from starting individuals fresh on treatment, you would have lots of people who are already on treatment, and the guidelines recognize that there could be many reasons why you would want to switch. Many patients we have now in our clinics are on regimens that are relatively old, relatively less favorable than current regimens, and if there was a reason and the patient was willing and ready, then it would be an opportunity to optimize their treatment and move them on to something else. The guidelines don't make specific recommendations about you switch from this to specific this, but they say these are the situations where you might want to consider a switch, and these are the considerations that you would take when you're selecting the new agent. And they're largely reflective of what I just said now about naive patients. So to conclude, current guidelines agree that rapid initiation is appropriate for most patients when the patient is ready and the clinical setting is appropriate. Generally prefer an integrase inhibitor, and it could be a part of 2-drug or a 3-drug, but if you're selecting 2 drugs, then you need to select your patients, and you need to individualize your patient, your regimen to the patient in front of you. And you can come up at the end with a relatively simple, easy to take, effective regimen, then you've ticked all the boxes. Thank you.
Thank you, Dr. Ali, for the update. Excellent presentation as usual. So any questions? Still we have like 1 or 2 minutes. Yes, please?
There is a question.
Yes. Yes.
Adipose has some negative significance and impact on the patients.
Yes.
Can you comment on that? Like
yes, sure.
Pericardial, liver fat.
Yes, no, thank you very much for this excellent question. There's no doubt whatsoever, well, there are lots of data, it's very clear. It's the visceral fat that is actually associated with increased cardiovascular risk, not necessarily your subcutaneous, the amount of subcutaneous fat you have. And there are studies that show it's not your overall weight, it's not your overall BMI. You could have what could be considered an acceptable BMI. But if you have too much visceral fat, then that increases your cardiovascular risk. And at the moment, the data that we have about weight gain in association with antiretrovirals does not go into this granularity. It describes weight gain, but it doesn't describe where does this fat go specifically. None of the studies did that so far. most of the discomfort that is reported is related to image, because a lot of people are not happy gaining 7 or 8 kilos of weight, and also by potential cardiovascular event. But you make a very important point that this weight gain is not necessarily a direct translation to an increased cardiovascular risk. The two are different. And the little secondary data from secondary analyses that we have suggests that that increased weight is not associated with increased cardiovascular risk, but the data are not adequate.
Thank you, Dr. Amrani. One more question. You didn't tackle pregnancy.
No, I didn't tackle many things. I didn't tackle pregnancy, tuberculosis, so many different conditions. I just stuck to starting 20 minutes.
You need another 20 minutes. But I believe that the issue of dolutegravir containing regimens have been so far documented to be the only valuable protocol for use in pregnancy, and maybe raltegravir as well. Bictegravir did not reach yet approval for pregnancy, correct?
Correct. Among us, the integrase inhibitors that are considered first line, bictegravir is not appropriate or suitable for pregnant women. That is, if you had a woman of a childbearing age who is planning pregnancy, or you're about to start a pregnant woman. There's very, very small amount of data, less than 10 women reported so far in the literature, who became pregnant on bictegravir and continued. They didn't stop. And they were not associated with failure.
But still very limited.
But you're absolutely right. The recommended regimens are dolutegravir or raltegravir, twice daily raltegravir, not once daily raltegravir, if you're using an integrase inhibitor, or otherwise use a non-integrase inhibitor regimen, yes.
Thank you very much. Thank you, Dr. Amrani.
Thank you.
As usual, a wonderful talk. It's my pleasure to introduce the next speaker, Dr. Hilal Al-Hashami, who is a pediatric infectious disease physician in Oman, has been actively involved in caring for HIV, AIDS, and other infections in pediatrics, and teaching at the university and students and residents. Dr. Hashami.
Assalamu alaikum, good afternoon. First of all, I would like to thank the organizing committee for inviting me in this meeting and in sharing or shedding light into the pediatric updates. So indeed, the whole conference is about adult and only 20 minutes to shed light on the pediatrics. So we'll try to cover most of the most important things in this regard. Bismillah, we'll start. So there's nothing to disclose here, and this is the outline of the presentation. We'll talk about mainly most of the presentation will be about how to prevent transmission of the HIV from the mother who is infected to her babies. We'll touch base on the how to start and to initiate the antiretroviral medications in a newly affected child. So as again, HIV in children, it's basically being transmitted from the mother to the children. Other routes of transmission are very rare. And from mother to child transmission, if we talk about the percentage, about up to 10% they can acquire the HIV infection in utero, up to 15% during the birth, and up to 20% from the breastfeeding. And we will touch base on this as well later when we come into how to manage newly exposed babies. So this is the first section of the presentation. And so all the newborn babies who are exposed in utero during in utero, they should have being put on prophylaxis treatment, and that which agent to use and for how long depends on different factors. Now the antiretroviral prophylaxis, they should be started immediately after birth, and it should be done within the first 6 to 12 hours. So that factor depends on the either maternal factors or the infant factors, and mainly the maternal factors, such as the mother's status of HIV, is she controlled, her resistance profile, how long before delivery she was started on antiretroviral medications, and also it depends on the baby's factors such as preterm babies. So the use of antiretroviral medication in children can be divided into 3 categories. They can be used as a prophylaxis, or they can be used as a treatment. And the one in the middle, this is the one of the updates, and people, they start to talk about presumptive therapy or presumptive use of antiretroviral medication in babies who are exposed to HIV and who are at highest risk of acquisition the HIV. So the prophylaxis, usually we use it in a baby who is exposed to a mother who is well controlled, just to prevent the infections. People, they use zidovudine for 6 weeks, and in case mother, she has uncontrolled viral load, she has resistant virus, or she has other viruses, other risk factors, then we use to treat it with combination therapy along with the zidovudine. Now people, they are talking about the presumptive therapy, where you use, you put the baby on 2 to 3 drug regimens till you rule out the infection. And the third category is the HIV therapy in a child or in a baby who is confirmed to have HIV infection. So so this is the risk factor that put the baby into high risk. So if the mother, she did not start it on antepartum treatment, or she is mainly diagnosed during the rapid test when she came in labor, or she started her antiretroviral medication, but she did not maintain the viral suppression within 4 weeks of delivery. Now, this is what we mentioned. So zidovudine is the widely used antiretroviral prophylaxis for retrovirally exposed babies, and the combination therapy, it's mainly kept for the high-risk babies. Presumptive therapy should be administered to infants with the mother who have primary or acute infection during the breastfeeding. So this is also another category where you will start the baby on the combination therapy. We mentioned that in pediatric population, we have limited choices of antiretroviral medications because lack of efficacy, lack of data, and as it was mentioned just in the previous presentation, the integrase inhibitors start to come into the picture, and we are starting to use it more frequently along with new recommendation in international guidelines. So for example, here it is only we have few drugs that can be used in preterm babies: zidovudine, 3-TC, and nevirapine. And the presumptive therapy, when we decide to go for combination therapy in case baby exposed to high risk retro exposure, then the period of prophylaxis, it can go up to 6 weeks, rather than only 4 weeks, in which in situation where the mother, she has controlled viral load, and her viral load is suppressed before the delivery. Again, some people, they are trying to differentiate between the combination therapy with 2 drugs as a prophylaxis, and between the presumptive therapy, and between the use of the zidovudine as monotherapy or as a prophylaxis. And just to make it simple, some experts, they advise to go, if the mother, she has undetectable viral load, then you go for the zidovudine for 6 weeks. If she has detectable viral load, but the viral load is less than 400, then you go for the combination therapy. If the viral load more than that, then you go for the presumptive therapy. So for a newborn babies who is diagnosed, whose mother diagnosed on just before or when she came in labor, so the baby, we should send the rapid test on the mothers, and ideally we should get the result within 1 hour. And but should start the baby on the presumptive combination therapy. Breastfeeding should not be started, and we should start the baby on formula till we work up and finalize the result of both the mothers and the baby. So this is the initial post-natal management of newborn exposed with HIV. And so basically, the mother should have, this is the, so the mother, she should have suppressed viral load before the delivery, and then the delivery either goes for the spontaneous vaginal delivery if the viral load is suppressed. If high viral load, then she go for the C-sections. After that, the baby will be started on prophylaxis, and that prophylaxis again, zidovudine for 4 weeks, or zidovudine with combination for 6 weeks, or now people talking about the presumptive therapy. Here, at this point of time, we usually get the call if the mother, she's planned for a C-section or for the delivery, they call us that we will be having a baby who's exposed to retroviral, and we will go and talk to the mothers. Explain to her how we will manage the baby and the potential risk of transmission of HIV or retroviral infection from here to the babies. And at that point of time, we stress on 3 or 4 things. One of them is the breastfeeding, it's contraindicated. And even in the international guidelines, people now, they are talking about to discuss it with the mother if she would push to breastfeed or not. I mean, and it also depends on the viral load on the mother if she's undetectable. People, they start to talk there, but I think we should stick, especially in this region, that the mother, she should not breastfeed the baby. We have the alternative of formula milk. So that's one thing that we'll tell the mothers. And also very important practical point is that, again, in our culture, when the mother, she goes home, her mother or mother-in-law will keep asking her why you are not breastfeeding your baby. So you need to secure that part and tell the mother how she should respond to them. After the other things, that the baby should not receive live vaccine. We should send his HIV PCR after birth, and we'll start him on zidovudine prophylaxis. After that visit, when he is discharged, we will follow him up in the clinic. We will follow him up in the clinic at 4 to 6 weeks to do the second PCR, and then 4 to 6 months to do the third PCR. And the third PCR, it's very sensitive and specific up to 97%, upon which you can decide that the baby, he can receive his BCG vaccine and he can receive other live vaccine. One more test remaining, that will be at 1.5 years, which is the serology. So we mentioned these points. Yeah, also we talk about these points here. Now, what are the potential side effects of sending the baby home with zidovudine? The most common side effect is anemia and thrombocytopenia, and it was anemia and neutropenia, which was initially illustrated in the French study. Around 15% they develop anemia, and 18% they will develop neutropenia. So now we'll move into the second part of the presentation, and almost we are half in regarding the times. So choosing the retroviral medication in children is totally challenging and compared to the adult. I mean, since morning, people, they are presenting the adult, and they have more than 20 sort of type of medication. We used to have AZT, 3TC, Calitra, and nevirapine. Now we are starting to use integrase inhibitors more. So, the choice to start the baby on antiretroviral medication depends on what do you have in your center. Is it available, the formulation, the drug resistance profile on the mother's, tolerability of the medications, and the frequency of giving the pills at home, and who is taking care of the child, and who will supervise the child or give the medication to the child or to the baby. But usually, The regimen consists of this, of the backbone of dual nucleoside reverse transcriptase inhibitors plus either integrase inhibitors or non-nucleoside reverse transcriptase inhibitors or boosted protease inhibitors. Now, the way how to select between them, if the baby he is less than diagnosed in less than 2 weeks of age, then you will put him on the 2 NRTI plus nevirapine. If he is more than 2 weeks, then you will put him on the Calitra, and if he is more than less than 4 weeks, but his weight is more than 2 kg, you will start him on raltegravir. Dolutegravir, if the baby's age is more than 4 kgs and he's weighting more than 4 weeks, and he's weighing more than 3 kg. In children who are more than 2 years and their weight is above 14, you can use either dolutegravir or bictegravir. So the one slide about the non-nucleoside reverse transcriptase inhibitors, they have long half-life, which allow for less frequent drug administrations. Also, there is a risk of dyslipidemia is much lower than the protease inhibitors, and the pill burden is less as well. The things they have, and we experience it in more than one patient, they carry the risk of developing severe hepatitis and severe skin reactions. Again, this table exactly shows the formulation or what are the regimen that you started in babies with HIV or retroviral infection. So you can see with the 2 NRTIs plus raltegravir in the first 2 weeks. Before 2 weeks, you start him on nevirapine and Calitra or leponavir, ritonavir after the 2 weeks of age. So why we need to shift from nevirapine to Calitra to the leponavir, ritonavir, because the data are more. It shows that the babies who are less than 3 years and they are on Calitra, they do much better compared to the nevirapine. One important thing is that although the guidelines, they gave you the age groups, they give you the weight, and they give you different regimen. The things that you want to keep in mind, especially that children, as I mentioned, we have limited choices. We don't have much like the adult population. If the baby he is on specific regimen and he's doing fine with that, he maintain his viral suppression and he's maintain his CD4 count, then you can keep him on the same regimen rather than exposing him to a different antiretroviral medication with potential risk of developing resistance later. What about the monitoring and following up the babies who are infected with retroviral infection? So absolute CD4 count can be used as an indicator of the immunity in children with retroviral infection, and it used to be that the percentage of CD4 count is an alternative to the absolute in children less than 5 years of age, but now we can use the absolute count as an indicator of the immunities. So when we should send the resistant testing, so ideally we should send it at the time of the diagnosis. We should send the resistant testing before we change to another regimen if the child he is failing the current regimen that he is on, as well as when you diagnose a baby whose mother has high risk of resistance profile or high risk of uncontrolled viral load. Genotypic testing, it's preferred. Phenotypic testing, you go for it when you expect complex resistance pattern. So after you put the baby on any regimen, then you need to follow him up within 2 weeks to check on the adherence, tolerability of the medications, and then you need to repeat his labs like viral load after within 2 to 4 weeks. So the follow-up, if you have that, we need to follow up the baby. We follow up every three months. The CD4 count, we repeat it initially. The first 3 months, if it is maintained, then the CD4 count can be measured every 6 to 12 months. But viral load, we carry it up and we do the testing every three months with each visit. And here we go. So I think with that, I finished. Just I tried to cover the how to manage the baby exposed to HIV infection in utero, as well as initiation of antiretroviral medication in children. I think we have 2 minutes extra.
Yes, still you have 2 minutes extra.
Thank you so much. Thank you for your attention.
Thank you for your update and excellent presentation. So any questions need to be addressed? Yes, please.
First of all, thank you very much for the informative presentation. I would like to ask about the breastfeeding and the HIV positive mothers. Is it absolute contraindication to breastfeed the babies? What if the mother viral load was low? Can the mother breastfeed her baby at least for the first 6 months, where the benefit of breastfeeding is it may outcome the risk of getting the infection? Actually, this is my first question for you. My second question is for Dr. Jamila. What is the regulation here in Bahrain to vaccinate, to avoid giving the children the live vaccine? Is there any regulation? Actually, I'm not very aware of that. Maybe in the MCH department, they have their own way. I'm not aware of any kind of regulation not to give the child the viral, the live vaccine. So, because I have to think about not to stigmatize the mother, so how I will direct the MCH and primary care not to give the live vaccine. Thank you.
Okay, thank you for this question. So if we look back into the breastfeeding and retroviral infection, initially, historically, how things went till now. Initially they sort of allow it in Africa, in very poor countries, because they can die of dehydration secondary rather than from HIV infection. And the most guidelines, either the North American or European guidelines, they said they have the alternative, so breastfeeding is contraindicated. Now they said if the mother, she has undetectable viral load, but again it goes in the same line that the early morning presentation, that undetectable is untransmissible. And they said undetectable viral load, that means there's no free virus in the breast milk, but could be cell bound. And with that, now some experts, they said you need to sit with the mother, negotiate with her if she again wish to breastfeed. But my own understanding is this, it's mainly in that specific age group where the mother, she will face that social pressure when she goes back, why she is not breastfeed the babies. And if time allow me, just 2 minutes. So in real life, when we sit with the mother, because we have one case who got retro exposure from the breastfeeding. Now what we will do that we'll sit with the mother, we'll tell her that the baby should not be breastfed. And usually the OB-GYN, they give them the tablets that they dry the milk. And you know, even in some families, the mom or the mother-in-law, she will sit with the young mother, she tell him, I will help you in breastfeeding your baby, to that extent. So, hopefully by keeping the baby in that 3 days, when the mother, she took that pill that dry the milk, when she goes home, she has no milk, and that will convince them. So that's that. In our region, I don't think, till we have more robust data from scientific data regarding the breastfeeding and the potential risk of transmission, and I think we can stick on the current guidelines that she should switch to the formula milk.
Thank you. Thank you, Dr. Mona, for the question. If I understand the question, you mean the vaccination, live vaccine in HIV patient or relative of HIV? Of a mother who's HIV. No, the guidelines are clear for vaccination. If you have immunocompromise within the, close, to a baby, we don't give them live vaccine. That's for sure. Yes. Whether you have immunocompromised, yes, yes. Yes. For example, oral polio or something that we stop it.
Jamila.
Okay, so, but nothing to be given to the mother, just to show to the health center not to give the live vaccine, nothing. Okay.
That's part of privacy of patient. So probably she will not say what she has. She doesn't need to say that she's HIV. She can say, I'm immunocompromised, taking medication. Yes, yes, that's they know about it. And, usually direct the patient or the relative, when they come to the clinic, we explain everything about the vaccination. What vaccine should they take or not? And, we tell them to inform the health center for the patient themselves, what to take, what not to take, according to the...
Thank you, Dr. Hilal, for your presentation. So now I'm delighted to present Dr. Ru'a Sultan Al-Usaimi. She's the third speaker in the afternoon session. She's internal medicine and adult infectious disease consultant since March 2020 at HIV Center of Excellence, East Jeddah Hospital, with a special interest in HIV management and research. Also, she's director of infectious disease fellowship program, as well chairman of antimicrobial stewardship program, East Jeddah Hospital. She's going to talk about 2 drugs versus 3 drugs regimen. Floor is yours, Doctora.
Thank you, Doctora. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the organizing committee. This talk is supposed to be presented by Dr. Ghassam, but unfortunately, he couldn't make it even virtually. So today I will present 2 versus 3 drug regimen in clinical practice. Is the debate offered? So no conflict of interest for my talk. So clinical thought, right off the bat, yes, both are recommended as first-line therapy, but the evolution of clinical data on practice and guideline, it's important to look at each patient differently. The devil is in detail. And finally, the caveat in case of rapid start. So I will start with this. Are we actually there now? 2 = 3? So the evolution of 2 drug regimen in HIV naive patients started from 1994 till 2013. Several 2 drug regimens has been developed, failed or underdeveloped. After that, in 2014, there is boosted BI with 3TC, proof of concept of efficacy by Gardel and this study, but still it's boosted BI with the complication and side effect of boosted BI. In 2017, the pilot study by Badel and ACTG 5353 showed the proven efficacy in single-arm study, which was confirmed by phase 3 Gemini 1 and 2 study in 2018. What about the other? We tried a lot of 2 drug regimen. The boosted lopinavir with efavirenz, boosted atazanavir with efavirenz, boosted lopinavir with efavirenz, and boosted darunavir with 3TC. Good virological response, but increased rate of side effect. And there is a lot of regimen failed to prove in efficacy. Atazanavir with raltegravir in Spartan trial, maraviric with boosted darunavir with raltegravir in the ACTG 5262, and boosted darunavir with raltegravir in harness switch. So why reducing the drug burden is matter? Because we want to make antiretroviral therapy safe without sacrificing virological suppress. We want to reduce side effect. We want to reduce drug-drug interaction, reduce cost, and potential for long-term success. So, sorry. What's the 2 drug regimen and approval status that have been found and approved by FDA? We have dolutegravir lamivudine, single tablet regimen. approved in 2019 April. It's indicated for first line and switch regimen. The second one is dolutegravir rilpivirine. It's a single tablet regimen also approved in 2017. It's only indicated for switch for virologically suppressed patient for more than 6 months. And the last one, it's long-acting captogravir and rilpivirine. It's injectable drug approved in 2021 for switch therapy. So in my talk, I will talk about the first two. The last one, I found that there is a separate talk about it. So, sorry. So what about the international guideline? All the international guidelines recommend the three-drug regimen and the two-drug regimen. Dolutegravir lamivudine is the first-line initial regimen for most people living with HIV, with the few exceptions. So it's recommended by DHHS guideline, International AIDS Society, and European. What's the few exception? Individual with viral load more than 500 is not recommended to use it. Hepatitis B co-infection. If HIV genotypic resistance is for reverse transcriptase or hepatitis B infection result not yet available. So this is the exception for using two-drug regimen as a first-line regimen. So the landmark trial for approving dolutegravir 3TC as initiation therapy, it's Gemini 1 and 2. It's randomized, double-blinded, non-inferiority multi-center trial. It's phase 3. It's for antiretroviral naive patients with very strict eligibility criteria. Viral load should not exceeding 500,000. No major mutation resistance, no hepatitis B co-infection or need for hepatitis C co-infection. It's enrolling 716 in the two-drug regimen arm, dolutegravir 3TC, with the comparative, the three-drug regimen, dolutegravir, TDF, and FTC. So the primary endpoint was in week 48, showing the efficacy of the two-drug regimen with viral load less than 50 copies per ml. So the virological response at after 3 years from enrolling showed non-inferiority margin. As we can see, the pooled analysis intention to treat analysis showed efficacy of two-drug regimen is 82 compared to 84% in the three-drug regimen arm. So the non-inferiority criteria were met for Gemini 1 and 2 throughout the study period. What about the confirmed virological withdrawal after 3 years from treatment? No treatment emergent integrase or NRTI resistance among any patient with confirmed virological withdrawal. The percentage of confirmed virological withdrawal in two-drug regimen was 2% compared with 1% in three-drug regimen. What about the mutation? Developing the resistance mutation, there was one patient confirmed with non-confirmed virological withdrawal on the two-drug regimen have developed resistance mutation. As we can see, started with baseline 93,000 with baseline CD4 393. The patient had non-adherence issue, developed resistance in week 132 and in week 144. This patient was withdrawal from the study and switched to dolutegravir boosted BI and became virologically suppressed after that. Okay. What about the, it's just for virological response at week 144? No, there is just as good as number for extraviral endpoint. The magnitude and the speed of viral load decline were similar between both arms, as we can see by week 4. Both arms confirmed virologically suppression, and the frequency of viral blip was comparable between both arms. What about the renal and bone biomarker? It was better with the two-drug regimen, which could be explained by the absence of TDF regimen, and lipid slightly better and three-drug regimen also because of the TDF effect on lipid profile. So the next landmark study for switching therapy, the TANGO study, it's multi-center randomized parallel phase 3 non-inferiority study showing the enrolling all HIV viral suppression more than 6 months and in stable tough containing regimen. So early switch to drug regimen versus continue on TAF-based regimen. Then after that, there was late switch phase. The primary endpoint was virological failure at week 48, then at week 144. So the analysis showed the two drug regimens showed efficacy 85.9% compared to 81.7% in TAF-containing regimen. So non-inferiority was met in intention to treat analysis, and there is superior suppression in per protocol analysis by week 144. There was no confirmed virological withdrawal in the dual therapy arms, and there was one patient in the TAF-based regimen arm without resistance, no resistance detected at failure. And there was 7 patients had proviral, 184 as baseline without any sacrificing the virological suppression. So what about the real world data about two drug regimen, the dolutegravir lamivudine? It was, there was 40 studies across the world, more than 7,000 patients, treatment naive and suppressed patients, showed higher rate of viral suppression, low risk of virological failure, and low rate of adverse effect-driven discontinuation. It's ranging from 1.5 to 8.5. So next regimen, we have a case. 43-year-old man with HIV, well-controlled in single-tablet regimen, rilpivirine, FTC, TDF, but with worsening CKD nephrotic syndrome. This patient had HLA positive. He would like to continue taking single-tablet regimen. Initial lab showing CD4 450, virologically suppressed, wild-type genotypes, hepatitis B immune, and hepatitis C non-reactive. He had estimated GFR 28 and hemoglobin A1C 5, BMI 28. This is the worst case scenario for any patient. So in this patient, we need agent with NRTI sparing regimen, despite being the NRTI the backbone of combination of antiretroviral therapy. NRTIs are associated with a lot of complications. The tenofovir regimen, proximal tubular dysfunction, osteopenia, osteoporosis, and osteomalacia. The abacavir cannot be used in HLA positive patient. Concern about use it with in patient with high cardiovascular risk. And the renal dose adjustment could complicate the ART dosing. So the next regimen we will talk, the dolutegravir rilpivirine, it's approved as switch therapy in virologically suppressed patient for more than 6 months, no history of treatment failure, and no mutation for or resistance for either dolutegravir or rilpivirine. So the landmark study for approving dolutegravir rilpivirine as switch therapy, it's SOWARD 1 and 2. It was a randomized, parallel, open-label, multi-center phase 3 non-inferiority study. It's enrolling all adults with HIV suppressed more than 6 months. At screening, no hepatitis B co-infection, no previous virological failure, and the switching either to dolutegravir rilpivirine or continue baseline ART. Then after that, late switching to drug regimen. So the primary endpoint was the viral load less than 50 was maintained 95% in each arms by week 48. And after that, at week 100, achieve 89% in the early switch arm compared to 93% in the late switch arm. So what about the mutation and confirmed virological withdrawal? It was 10 patients had out of 990 confirmed virological withdrawal. Treatment emergent resistance was found in 3 patients among all patients. And this is the detail. One patient was on evavirenz-based regimen. They have mutation K101, confirms at week 36. The second patient at week 88 developed resistance to E138E. And the third patient at week 100 was an evavirenz-based regimen, develops mutation to NNRTI. For the 3 patients, switching done, and they confirmed for suppression after that. What's about the real-world data? The retrospective analysis of clinical characteristic and outcome to dolutegravir rilpivirine from January 2018 to December 2018 in OBRA study. Total number of patients was 880. There was 88% remained on drug at 12 months. Biological failure occurred only in 1.5%, and there was 12% discontinued the medication. 41 of them were virologically suppressed. So, how about different scenario? This is 37-year-old female patient, generally healthy, referred to you after being diagnosed with HIV this morning. Other baseline lab including hepatitis B, renal function normal. She's willing to start treatment today, 1 tablet preferred, but only if you think this is a good idea. So what about rapid start for 2 versus 3 drug regimen? So rapid start means same day of diagnosis, day of entry to care. It's defined by most of study less than 7 days from diagnosis. Should not involve more than 1 trip to the clinic. Doesn't require waiting for the lab result. As we hear today about the benefit of rapid antiretroviral therapy, it's coming from systematic review for RCT. It's the same day starting, it's increased ART initiation in the first 90 days, patient retentions and viral suppression at 12 months, and benefit in mortality. So what about 2 drug regimen as rapid start? We have only this study. It's rapid initiation of dolutegravir lamivudine. It's multi-center, single-arm, open-label phase 3 pilot study. A treatment for HIV-naive patient diagnosed within 14 days, enrolled to fixed dose combination of dolutegravir lamivudine. The primary analysis done at week 24 and end of study at week 48. So the result showed, virological outcome at week 48 in any of antiretroviral therapy was 97%, compared to the dolutegravir lamivudine arm was 97%. And in intention to treat analysis showed in the 3 drug regimen 82, compared to the 2 drug regimen 76%. So this is the discontinuation or pulling out from the study. 5 patients because of hepatitis B positive. 1 patient had baseline M184 mutation. 2 patient participants going by their choice. Pregnancy was 1 reason for withdrawal from the study. What's about the recommendation by guideline? Still, the 3 drug regimen is only recommended by all the international guideline for rapid start. 2 drug regimen is not recommended due to higher rate of transmitted NNRTI and NRTI drug resistance. So, in conclusion, 3 drug regimen were rightly the gold standards when needed 3 drug. 2 drug regimen based on high barrier and boosted drug are just as efficacious and as 3 drug regimen. 2 drug regimen with boosted BI offer a little advantage, and as we can see, we are all going to less drug era because of the developing of new medication. And thank you.
Thank you very much. That was a very, very good talk. And personally, I find it quite difficult coming from an age where we used to use 3 drugs and sometimes boosted protease inhibitors. So I find it very difficult. However, the key issue has been the impact of a very high resistance barrier of dolutegravir, allowing us to use as dual therapy. And I'm sure that pretty soon will be dual therapy with bictegravir because it also has a very high resistance barrier. Any questions from the group, please? Any comments? Okay, thank you very much, Dr. Ruat. So, last but definitely not least, it gives me a great pleasure to introduce my very good friend, dear Dr. Ali Ghalib from Oman. Dr. Ghalib is the lead consultant in infectious disease on HIV for the clinical services at the National AIDS Program in Oman. He has worked in the UK after training in the UK as an HIV specialist and worked in HIV, then in Oman, with a very special interest in cascade of care and HIV resistance. He is multiply published, and he is definitely an outstanding speaker. Dr. Ghalib will talk to us over the online. Where is he?
Hello,
Here he is.
Yeah, can you hear me?
Yes, we can hear you.
Yeah, hi. Just if you can allow me to share my video and my slides, please. Start my video and slides, or at least share my slide. Yeah, I can do that, yeah. Yeah, hello, can you hear me? Can you see my slides?
Can hear you, we can hear you.
First, thank you very much, Jack, for the kind introduction, and hello everyone. And I would like to thank the organizing committee as well for invitation. And I wish I was able to attend in person. However, due to prior commitment in another conference in Cairo, so I'm speaking to you not from Muscat, from Cairo. So in the next 20 minutes, I know it's the last talk in the day, so I would like to make it light. And unfortunately, when you talk about new agents, you can't avoid talking about data. So I'll try to minimize the data and the number crunching, and I'll try to answer the following questions. How ART have evolved over time, and we'll ask the question, do we really need new agents? Because now HIV treatment, most of the speakers have said that, is very tolerant, very easy, very convenient. Why then we need to think about new medications? And then we'll talk about some recently approved new agents and what the future will look like when it comes to ART. So first, I would like to start by maybe looking in the past, because it's always good to reflect and look at the past in order to realize and appreciate what you have. And ART has really evolved over the last, I would say, since 1987, have really evolved significantly. And since the discovery of the HIV in 1983, then the AZT came in 87, and then people started using AZT, D4T, DDI, but they were toxic and they were not really good enough to bring the viral load down or to maintain long survival of patients. However, the milestone occurred in 1996 when protease inhibitors were discovered, and particularly in Indinavir. And that really changed the HIV landscape, and people were surviving. However, at a very high price for patients. And if you look at the picture there, that patient holding in his hand 20 tablets, that the patient was taking lamivudine, 2 tablets, 1 in the morning, 1 in the evening, zidovudine, 2 capsules 3 times a day, and Indinavir 4 capsules 3 times a day, and he has to take it on empty stomach and drink a liter. So it's really not convenient. And then you move forward, 2006, single tablet. We thought that was a holy grail. We don't need anything else. However, the integrase inhibitors came in 2013, especially the second generation, dolutegravir, bictegravir, and that really made life very easy for patients. And then from 2018 onwards, people looking at even challenging status quo. Do we need to have really 3 drugs? And we've heard the talk about the two drugs treatment. But people talked about new medications and new methods of delivery. So the question is, do we really need new agents? Yes, we do, because we still have very small number of patients who are really failing everything. And if you want to not leave anyone behind, we should look into new medication, especially new classes, but also patients who are already taking their medications. Some of them, they get pill fatigue. Some of them, they have poor adherence, although they have a viral load suppression, but they're not great with medications. And some people still tell us, where are the injections? Because whenever they take a tablet, they just remember that they have the infection. And this is really causes them like internal stigma. And also simply it just gives people choice, so people can either go for injection or tablet. So this is one of the first one I would like to talk about is fostemsavir. It was approved by FDA in July 2020. It is a novel attachment inhibitor. It binds to the GP 120, so it blocks the attachment and the entry. As you can see, it was only used and it's only licensed for people who are really failing treatment, so that unmet need. And there were 272 patients, and they were failing everything. You can't construct a regimen for them. So they were randomized initially only for 8 days just to see whether the drug would work on its own. So like for 8 days, they wanted to see the viral load drop after 8 days. And then after that, it was open label and everyone was given fostemsavir for that. The data was very impressive. The viral load decay was 0.8 log in the fostemsavir and 0.2 in the placebo arm. And the viral load suppression, it's less than 40, it was 60%. Obviously, it's not like your typical 90% in naive. This is, remember, these are really very difficult to treat patients who really don't have many options for. The second group I would like to talk about, it is cabotegravir and rilpivirine injection, and this is was approved in January 2021. And cabotegravir is very similar to dolutegravir, but it has the advantage of being used in a nano formulation, which would allow long-acting property. And rilpivirine, we've known rilpivirine for a long time, but we've known it as a daily tablet. You give it with the FTC TAF or with the FTC TDF, but also with the nano technology, it's allowed using for long term. So these two studies, and they're very similar, Atlas and Flare, and in the nutshell, both of them, they were used in switch therapy. It's not for naive patients. And in Atlas, patients who were stable on ART, 600 patients were switched to cabotegravir rilpivirine every 4 weeks as an injectable. In Flare, patients were being VIV medications. It was the patients were put on dolutegravir, abacavir, lamivudine as a single tablet, and viral load suppressed at week 20, and then they were randomized similar to Atlas. And just bear in mind, patients before put on cabotegravir and rilpivirine, both of them, they had a lead-in, like an oral lead-in for 4 weeks, just to make sure that they're tolerating the injectable. The data, very impressive. And as you can see, the viral load suppression in both arms, more than 90%. This is an Atlas study. When you move on to Flare studies, again, very similar, very impressive, 93% in both arms, whether the patient was on long-acting cabotegravir, rilpivirine, or dolutegravir, abacavir, lamivudine. And the safety profile also were very good. Very few patients discontinued the injectable because of the injection site reactions, and also the resistance profile were favorable as well. And then the 4 weeks work, and then people thought, oh, what about 8 weeks? It's all about pushing the boundaries in HIV field. So what in Atlas 2M, it's also randomized, but this time people from Atlas study, which were taking 4 weeks the injectable, and also the patients who were on oral medications were switched to either cabotegravir, rilpivirine every 4 weeks or every 8 weeks. And just to answer a simple question, would 4 weeks work similarly, or would 8 weeks work similarly as 4 weeks did? And the answer was yes. So both arms, you can see, both of them roughly 94% viral load suppression. Right. This is the last one, which I'll be talking about when it comes to new medication. This is, it was only approved last month, August, and it was only approved in Europe because the FDA rejected the initial application from Gilead, and it was primarily for manufacturing purposes because the glass in the vial, they thought it would react with the actual medicine. So now they will revisit the application in December this year, and is very likely to be approved by FDA. However, in Europe, it was only approved for people who are heavily treatment, who they don't have many options. So it's not approved for naive. And once I take you through the data, you would probably realize why that's the case. So what is it, lenacapavir? It is a capsid inhibitor. It is a very novel, it's first in class, it's a very long acting. And just to remind you what the capsid is, it is a protein which is surrounding the genetic material for the HIV. So the virus, once it gets attached, this capsid, it has to be disintegrate or disassemble in order to release the genetic material inside the cell. And then after the replication inside, what will happen, the virus will replicate, but it also, in the end, it wants to mature and produce new variants. So the capsid will reintegrate and reassemble again in order to have a mature infectious virus. And the capsid inhibitors block those two stages. So it works at two stages. So the first study is Calibrate, and this is for naive patients. It's about 200 patients, 180 patients, and they were randomized at 4 groups. The first one, standard of care, it's bictegravir FTC TAF. The second group is lenacapavir with FTC TAF. And then the third and the fourth group, both of them were given the subcutaneous injection. So it's a very long acting, you can give it every 6 months. So the patients were given the injection of the capsid inhibitor, and both of them with FTC and TAF orally. So you can imagine this is someone who's taking FTC TAF daily, but the capsid every 6 months. This is why it doesn't make sense in naive patients. It defeats the purpose. So you need to have to take something orally. So in this study, after week 28, then the patients were simplified. The people who were injectable capsid with the FTC TAF, they were simplified to 2 drugs. And obviously, Gilead wanted again to push the boundaries and to give only 2 drugs. And because maybe the future as well will be only taking 2 drugs. So they will have long acting and 2 drugs as well. And the result, again, very impressive. If you look at the far right, when you look at the FDA snapshot, the viral suppression across the board was above 90%. The second study, which is more important from licensing point of view, it's very similar to the initial study, Bright, which was used for licensing fostempravir. This is a very heavily treatment experienced patients. It's only 72 patients. As you can imagine, they're not easy to find, and you can't construct an effective combination for them. So there were 2 groups. The first one was randomized to either giving them oral capsid inhibitor with their failing regimen, or they're just failing regimen. And also they wanted to see after 14 days what would happen to the viral load decay, and whether they would have a good more than 0.5 log drop in the viral load after only 14 days, which is a functional monotherapy. And then after that, all of them, they will switch to the injectable. And then the non-randomized one is only 36 patients straight into oral and then subcutaneous capsid inhibitors. And you can see this circle in red that it's again, lenacapavir worked very well, and 88% of the patients in that group, they had more than 0.5 log drop compared to only 17% in placebo. When you look at the efficacy data, which is the viral load suppression at week 26 and week 52, you can see on the far left, 81% achieve viral load less than 50 at week 26, and this increased to 83% at week 52. However, it's just very important to realize that here on the right, that when the viral load efficacy is stratified by how many effective drugs were there in the background with the capsid inhibitor, it showed that the more drugs you have, the better. So if you only have 1 effective drug in the background, the suppression was only 67%. If you don't have any, if you have 0, the suppression was 67%. If you have one, 79%. But if you have two or more, you have a very high viral load suppression. So it just shows you that it is good, it's efficacious, but you can't use it alone. You can't use it as a monotherapy. Right. So what when it comes to ART, the pipeline is really far from dry. So also we have islatravir, which is a nucleoside reverse transcriptase translocation inhibitor. So it's a novel mechanism as well, and it has shown efficacy. It has been tried with Dravarine. It is an MSD drug. It's also used with capsid inhibitor. It showed very good data. You can give it weekly orally, you can give it monthly, and you can give it as an implant for 6 months as well. However, there was a setback last year. It showed that it caused lymphopenia and CD4 decline, and FDA has put the drug on clinical hold for the time being. So we will see what will happen in the future. Another drug, which is GSK, followed by 6 digits, it still doesn't have a name. It's an investigational maturation inhibitor, and it's very early development. The MK-8507, it's again an MSD drug. It is also very early in development, next generation NNRTI, but it has a beauty of less side effects compared to previous NNRTIs, and also it works against most heavily resistant viruses for NNRTI medications. And finally, we have broadly neutralizing antibodies. This also, they work by combining the interacting with the GP120, so they would prevent attachment and entry, and you can use them alone, you can use them in combinations, but you can also use them in combination with other long-acting agents. And the data is very promising, and you can give them every 3 to 6 months, but it's still very early data. So finally, just imagine your patients maybe in few years down the line, not very long. And so gone those days when you ask patients, how many tablets did you take? How many tablets did you miss? So there won't be probably daily tablets. So people who want orally, they will have the option of taking once weekly. You can give them islatravir with MK-8507, or maybe islatravir with the capsid inhibitor, or some patients will go from capitagrel rilpivirine every 2 months. They will have a nano formulation, and they can have it every 6 to 12 months. Or they may have an implant, which you can give every 6 to 12 months using TAF and islatravir. And also you can give them patches as well. So it's very interesting to see how we can take adherence history when those days come. And I would like to conclude, and well in time, well before time, because it's the last talk. I hope that you would agree that I've shown you that ART have evolved over the years, and they will continue to evolve. Despite the HIV is well treated, people do very well on the current medication, very clean medications, but still there is unmet need, but also there is always the search for improvement, for new classes, for long acting. And as a result, there are several innovative ART in the pipeline. Thank you for listening.
Thank you very much, Dr. Ghalib. That was clear and outstanding and comprehensive. Thank you very, very much. And as the chair, I take the opportunity to ask the first question. Are you still online?
Yes. Thank you, Jack. Thank you.
Okay, great. First, there is one thing that worries me. When we are presenting and simplifying so much treatment and telling people, because a lot of our patients are coming, so what about the next 1 month injection? What about the next 6 month injection? Because they read the media, they read the internet. So I'm really worried that people will become more and more complacent about antiretroviral therapy, about the use of treatment, and about preventing HIV. Now that's my first philosophical question, if you wish. And I would like you to comment on that. My next question is that, what is the prospect of these approaches on a monthly basis or 6 monthly basis for prevention? And this is, I think, a very interesting approach also for a long-acting PrEP.
Okay, thank you, Jack. Yeah, I mean, it's a very valid point, Jack, and you always, you raise this like provocative kind of discussion, and it's true. However, we just we have to be very honest with the patients, and this is the way it is. HIV treatment has become very easy, and it's very easy medically that you can live with HIV. However, I always tell my patients, we don't want to underestimate the fact that HIV is still unique, still a public health threat, it still has got an impact on the social life and the economy and everything. But we will give them the options, but they will need the support, because this injectable, when they miss a dose, sometimes it's not as easy as people think. And I think when it comes to implementation, it won't be as easy as we always tend to put it. So that's my take on your first point. The second point is very true, because it works really very well in prevention. Cabotegravir, there is a recent data, and it has been approved also for prevention. You can give it every 2 months as PrEP, as you would expect. It's shown superiority to FTC TDF in preventing new infections. It's just because you overcome the issue of adherence, you overcome the issue of having a partner you don't have to disclose. So it's really, yeah, definitely there will be a good place, including our own region, for giving people injectable every 2 months without worrying about the stigma. And even now they're talking about giving an injectable which has got a contraception as well. So you can use it for women as well. So they don't need to worry about pregnancy.
Thank you very much. I think with these simplifying treatments and prevention, it will hopefully bring some kind of normalcy to the care of HIV, and will get them out of the exceptionalism that they have been facing, and maybe will stop countries from mandating, stigmatizing persons, and rejecting individuals from work in some institutions, and I believe that will be extraordinarily useful for the future. Any questions from the audience? Well, thank you very much. I'd like to conclude this day then. Thank you, Dr. Al-Ghalib. It was nice to hear you, although we did not see you, but that's okay.
I think the video was not allowed, but thank you. I'm seeing you. That's a good thing. That's a pretty sign. At least I can see your pretty face. And I like the beard as well. I like the look.
Thank you. Well, do not forget, we have another day tomorrow. So we'll meet again tomorrow morning at 8:30 sharp. Please be here. And we start with very interesting sessions tomorrow morning on HIV and tuberculosis, opportunistic infections, malignancies, etc. So it's a very exciting day tomorrow morning. Please be here on time. Thank you.